Ma'am, wait 1 or 2 minutes, technical issue.
Okay, sure.
Just ma'am, 30 seconds, ma'am.
Okay.
Ma'am, we are live in 3, 2, 1. Please start, ma'am. We are live.
Namaskar and good evening, everyone. I welcome you all for today's webinar on Oncology Update. And with immense pleasure, I would like to invite Dr. Manish Sharma, who is Consultant and Head of Unit Medical Oncology, Rajiv Gandhi Institute, Delhi, for the welcome and introductory note and to take the proceeding further. Over to you, sir.
Thank you so much, Geetika. And at the outset, I welcome you all my colleagues, friends, all the postgraduates, TNB students here who have joined this medical webinar. And this is the webinar on oncology update. And at the outset, would like to thank our academic partners, Lilly, Roche, Zydus, and AstraZeneca for helping us to proceed with this webinar. And this is a 2-day webinar. So today, oncology update we will be presenting. So we will have multiple sessions. Day 1 is dedicated to breast and ovarian cancers. And the day 2 is dedicated to mainly lung cancer. So in the whole of this academic exercise, we have multiple sessions. We will be discussing upon the next generation sequencing. We will be discussing upon the personalized care of ovarian cancer patients using HRD as a clinical tool. We will be having few updates from ESCO. We'll also be having few updates about the FASGO, which is a newer formulation of pertuzumab and trastuzumab in our combination. And on day 2, we will have plenty of discussions on lung cancer, uncommon mutations, neoadjuvant immunotherapy in this setting, then extra extensive stage SCLC, lung disease, the role of atezolizumab. So we have seen a frequent upgradation in different treatment of ovarian cancer and breast cancer. So today we will be starting our talk by Dr. Arun Kumar sir, and he is therapy area expert, personalized healthcare in Roche Foundation. So he'll be taking this session, what to look for NGS report, reading between the lines. So many times when we come across an NGS report, we become confused what to look for, how this test is conducted, what for it is conducted, and how to look for a best quality report in a NGS, and is there something which physician can read between the lines without getting confused. So I welcome you, Dr. Arun Kumar. Kindly take the session ahead.
Thank you, Dr. Manish. Thanks for the kind introduction. I will share my screen. I hope my screen is visible.
Yes, Dr. Arun, quite
Good.
visible, and you are also visible.
Good. Thank you so much. Thank you, Dr. Manish, and thank you, team, for having me give a talk on the aspects of understanding an NGS report. So I'm basically a geneticist. I work as the therapy area expert for personalized healthcare at Roche. So today I will be talking a bit about the nuances to look for in an NGS report, and these are the disclaimers. And the agenda is I will give a very brief introduction to CGP, comprehensive genomic profiling, and NGS. Followed by what are the components of the report, a brief outlook of the report, overview of the report. Then I will deep dive into two particular cases of comprehensive genomic profiling reports and how one can exploit the report to the best possible way so that the maximum information is extracted out of a report. So for this, it might be a bit redundant, but for the sake of covering the basics, I'll just give a very brief about what NGS and CGP is. So essentially, any cancer is caused, the genomic mutations in a cancer can be classified into four major types. One is the common base substitutions, where a single point mutation happens. Say, for example, in this sequence, ATAGC, it becomes a ATCGC. The A has become a C, which leads to change in the protein's amino acid codon. And almost 95-96% of all mutations that we come across in various tumors are belonging to this particular class of mutations called as base substitutions. Best example is the BRAF V600E, and you have so many other point mutations. Then you have the insertions and deletions, where you could have a single base getting inserted or a single or a few base getting deleted. Best examples include the EGFR exon 19 deletion, where up to 20-30 bases can very easily get deleted in the coding region of the gene, and that causes the oncogenesis, that causes the activation of the pathway. Then you have the copy number alterations, where instead of one copy in a particular chromosome, the number of copies in the same chromosome increases. Best examples are your HER2 amplification or your MYC amplification, etc., where the number of copies of the gene in the same chromosome increases. So in a cell, we will have two copies, one in each homologous chromosome. The number of copies can increase to 5, 10, 20, 30 also in certain cases. And lastly, the most complex type of genomic alterations includes rearrangement. So rearrangement is an event where a gene from one chromosome gets cut and pasted near the gene of another chromosome. So essentially, this leads to a fusion of two genes that results in chimera. So rearrangement is basically chromosome getting rearranged between two chromosomes, whereas gene fusion is a result of a rearrangement where you get a gene fusion. For example, EML4 ALK fusion or NTRK gene fusions, NTRK1 fusions, or EWSR1 fusion. So a point to be noted is not all rearrangements actually cause a gene fusion. There could be rearrangements where the gene is cut, but it is not pasted with another gene, so you don't get a gene fusion event happening. Now, next generation sequencing is a technology that can detect all these four classes of genetic aberrations in a very accurate format. So basically what happens in an NGS technology is whenever you have a sample, you extract the nucleic acid from it, you chop the nucleic acid into 150 base fragments, and then you hybridize them with what is called as baits or probes. So these probes are the genes of interest against which are sequences of the genes of interest. So we have, say, 22,000 genes, and I'm interested in sequencing only 100 or 200 genes. So these probes are against those 100 or 200 genes, and you capture those genes and wash away the remaining part of the genome. and you end up sequencing this regions of interest using a sequencing chemistry. Now, I'm not going to go into the details of sequencing chemistry. You have at least 4 or 5 major types of sequencing chemistries, but the most common type of sequencing chemistry is the Illumina chemistry. So this is exactly what happens in the lab aspect of an NGS. But once the data is generated, then comes the real challenge of data analysis, where you have billions of these 150 base fragments which are mapped to the reference genome, and you identify mutations and make clinical and biological sense out of it. So NGS also comes in various flavors, what is called as a hotspot testing and a comprehensive genomic testing. So essentially what happens in a hotspot testing is that, say you have the EGFR gene and you test only the exon 19 deletion or L858R or T790M mutation, that becomes hotspot. You don't sequence the rest of the parts of the exons, or you don't sequence the rest of the parts of the gene. Whereas in a comprehensive genomic profiling, you end up sequencing the entirety of the gene. Why this is important? Because as we sequence more populations, we see that hotspot testing alone might not suffice, or might not, it has the potential to miss certain mutations. So that's why the comprehensive genomic profiling is definitely suggested by, definitely suggested to take the complete genomic profile into picture. Then you have a comparison of the various techniques. Say you have a capillary electrophoresis, which is Sanger sequencing, IHC, FISH, PCR, hotspot, and CGP. And you see that base substitution can be captured by almost everything excepting immunohistochemistry and FISH, whereas copy number alterations are very well captured by IHCs and FISH. But it is the comprehensive genomic profiling that might be able to capture the entirety of all 4 major classes of genomic alteration. So with this background of having understood that comprehensive genomic profiling is the best method to capture all possible genetic aberrations in a tumor sample, it is our practical experience that comprehensive genomic profiling also produces a lot of information in the report, which sometimes is overwhelming to understand, overwhelming to interpret. And in this lecture, in this talk, I really wish that I would be able to convey certain aspects or critical aspects of the report, which one might be able to interpret further. So what are the various components of a report? So first, I will just talk on the overview of the components of the report and use certain case examples to understand how best we can utilize a report. So overall, the report looks like this. You first have the basic patient demographics, what is the disease, and the specimen types and everything. Then comes the major biomarker findings. So in this case, the biomarker is the microsatellite and the tumor mutation burden, which are the biomarkers for information on the immune therapy possibility. Then you have the list of genetic variants identified in the tumor. So for example, in this case, you have the EGFR exon 19 deletion, CDK12 mutation, MTAP loss, etc., and TP53 mutation. Then you have the genes related to the tumor type with no reportable variant. So this is a lung adenocarcinoma. So you don't have reportable. So we know that for lung adenocarcinoma, EGFR, ALK, RET, ROS, BRAF, ERBB2 are quite important. MET are important because they are targetable. So except EGFR, the other genes related to lung adenocarcinoma that are targetable don't have a mutation in this. Now, it also highlights the major therapeutic implication or the clinical implication of the report, where targeted therapies with NCCN categories are identified. Basically, these are the drugs that are available for EGFR exon 19 deletion. So the drug recommendation comes like this, wherein you have 2 columns. One is the list of all the drugs that are relevant to the patient tumor. So this is in line with the AMP classification, that is the American Molecular Pathologist classification, where tier 1 variants are the variants which have a direct FDA approved drug for the particular tumor type. Now, tier 2 variants are those variants which have a therapeutic significance in other cancer types. For example, anti-EGFR antibodies such as cetuximab are implicated not in lung cancer, but in colorectal cancer. So in that case, it becomes tier 2 variant, which is the therapies with clinical relevance in other tumor type other than the one that the patient has. Then you also have genetic variants identified in the tumor with no approved therapy. For example, CDKN2A or B does not have a approved therapy currently available for the patient. Now it goes on to talk in detail about the type of variant. So here I request you to kindly have a note into the variants, the details given here. Most importantly, apart from the alteration, which we have already seen as exon 19 deletion, there is also something called as a variant allele frequency or the variant allele fraction. Now, this is a very, very important underutilized clinically relevant information that is there in the report. So in this case, the variant allele frequency is 40.7%, which means that of the all the DNA that we extracted from the tumor specimen, 40.7% of them had the particular exon 19 deletion. Now, while I'm talking about the case, I will show you how best we can utilize this particular value. Then it talks about the description of various studies and clinical trials that have gone before, that have undertaken, that have been done for giving therapies against the EGFR exon 19. And you also have the frequencies of the mutation in the particular cancer and the prognosis of the mutation in the cancer. All these are given. Then each drug that can be applied and along with their supporting data, the clinical trial data, is given individually for the particular report. And lastly, you also have clinical trials that can be that have the particular genetic mutation identified in the patient as an inclusion criteria. For example, in this case, there is a CDK12 splice site variant, which is essentially a variant of CDK12, which is pathogenic in nature. And these are the list of clinical trial along with the trial number, the trial title, etc., and the location where the clinical trial is happening, which is also given in the report. If at all the patient has an opportunity to get enrolled in this trial, the patient will definitely benefit from it. Now, having seen the various parts of the report, I will deep dive into what are the various molecular insights one can get from a CGP report. So this is a case of a 54-year-old male, non-smoker, and the patient had carcinoma, adenoma carcinoma of the lung, and there was a brain mets and bilateral pulmonary nodules were also there. And initially, the patient tested positive for ROS1 by immunohistochemistry. And before the ROS1 was done, I think the patient underwent whole brain radiotherapy because of the brain mets, and 4 cycles of PEB carbo combo was given. But there was a stable disease, and then the crizotinib was added because of the ROS1 IHC positivity. The disease progressed, and then the patient received Bev plus docetaxel. And now the patient was on maintenance therapy, but the disease was still stable. So the sample was sent for tumor comprehensive genomic profiling in the tumor tissue. Now, this is what is the major finding of the report. What do we see? We see a CDK4 amplification, CTNNB1, that is beta-catenin mutation, APC gene mutation, and you have many genes amplification along with PIK3C2G and a TP53 mutation. Now, the most critical aspect is there is no ROS1 fusion. Now, that could be the reason why the patient did not respond to crizotinib, because ROS1 immunohistochemistries are known to have false positives. So a confirmatory test is very important. Either a FISH or NGS like this is definitely important to know whether the IHC is a true positive or not. Now I'll come to the variant allele fraction story of this. Now you see, the CTNNB1 mutation has a variant allele fraction frequency of 7.9%, APC 18.4, PIK3 18.5, and the 2 TP53 mutations have 26 and 30%. Now, what does this suggest? This clearly suggests there are multiple clones of cells in the tumor with different mutations. For example, the most dominant clone is the TP53 clone, followed by the APC and the PIK3C2G mutation. Now, you see the variant allele fraction of APC and PIK3C2G is almost similar, which means that these 2 mutations could be in the same clone of cell. And there is a new clone that is arising that has almost 8% of beta-catenin gene mutation. Now, how to deep dive into this? Now, overall, if you see this, there are no targetable mutations. That's what one would conclude. But let us try to understand the molecular nature of the tumor. So the doing a comprehensive genomic profiling not only tells you what to do, it also tells what not to do. And most importantly, it helps you understand the molecular nature of the tumor. And over time, every tumor's molecular nature changes. So first, let us see what is the role of CTNNB1. Now, number one, where the take-home message here is there might not be any point in having immune checkpoint inhibitor here, because the TMB is 0, MSI is stable, PDL1 was also negative, and most importantly, the beta-catenin gene, that is the CTNNB1 gene, has a mutation. Now, this mutation is known to be showing a negative correlation with the tumor infiltrating lymphocytes. So CTNNB1 mutated tumors have shown to have resistance to ICI, immune checkpoint inhibitors. Now moving to the next APC gene mutation, it was a G2610 start, meaning that at the 2610th amino acid, when there was a G that has got deleted. So the protein stops with this position. So this is an inactivation mutation, meaning that this mutation does not activate the protein. This mutation actually controls the expression or the function of the protein. Now, of course, we know the APC gene activates the Wnt signaling pathway. Basically, the APC binds with beta-catenin and degrades the beta-catenin by ubiquitination. So when the APC is not binding with the beta-catenin, the Wnt signaling pathway activates. So what does this mean? Inactivation mutations in APC leads to activation of the Wnt signaling pathway. Now, of course, when there is a mutation in APC, it means the Wnt signaling pathway is activated, and it is also shown in murine models that Wnt signaling pathway also activates the PIK3-AKT mTOR pathway, and mTOR inhibitors are found to reduce the tumor burden in FAP mice models, that is the familial adenomatous polyposis mice model. Of course, this is a lung cancer, it is not indicated, but this is a study that is available in the literature. Now, coming to the beta-catenin mutation, it is an activation mutation. So what does this mean? Even if the mTOR pathway is activated, beta-catenin activation is shown to show resistance to everolimus or other mTOR inhibitors. Now, second one is, which I already told, beta-catenin is also associated with resistance to immune checkpoint inhibitor, and it is seen that it is seen more commonly among female patients, non-smokers, and no significant effect on the relapse-free survival was also observed. This is what we could understand from APC and beta-catenin. The third one was a HER3
Sir, sorry for interrupting. Kindly conclude your talk, please.
Sorry?
Kindly conclude your talk, please.
Yeah. So HER3 amplification was also identified, which is associated with poor prognosis and metastasis development. Lastly, the most interesting one in this case was the CDK4 amplification, which is, as we know, CDK4 is the cell cycle protein, which makes a cell, promote the cells to undergo the G1, go through the G1 cycle phase. And in non-small cell lung cancer, CDK4 inhibitors like palbociclib and abemaciclib have been shown certain activity where the median overall survival has improved. So what happened is the clinician after this had got palbociclib, and the patient is now on palbociclib therapy, and the patient is doing fine as of now. So the key takeaways from this report was ROS1 mutation, the ROS1 that was detected by IHC was wrong because NGS did not detect. Immune checkpoint inhibitors are not indicated, and CDK4 amplification promotes a cell cycle through the G1 restriction point, and CDK4 inhibitors can be tried if the patient is on later lines of therapy. Lastly, I'll just conclude with one case, again, a male non-smoker, the lung cancer case. But what we found interestingly was a BRCA mutation, KRAS mutation, GNAS mutation, and a SF3B1 mutation. Now, BRCA is a splice site variant. Of course, in other tumor types like ovarian or breast, it is indicated for PARP inhibitor therapy. But the variant allele fraction was 48.2. So whenever the variant allele fraction, especially in genes like BRCA, is closer to 50, it is suggestive of a germline origin. And after we saw this, when we checked with the patient did have a very strong family history of cancers. And so further confirmation of the germline nature is being tested. And as we know, whenever a patient has a BRCA mutation, it is sensitive to platinum or PARP inhibitor therapies. Interestingly, the patient also had KRAS and the GNAS variant. Now, studies have shown that whenever a patient has both KRAS and GNAS mutation, it is most probably a mucinous type of carcinoma, adenocarcinoma. And in fact, in this particular case, now the pathology was re-examined, and it was in fact found to be a mixed mucinous type of carcinoma. So what did we understand from this? One, BRCA mutation is in the could probably a germline, and one can give a platinum or PARP inhibitor. Co-occurrence of GNAS and KRAS mutations are suggestive of invasive mucinous adenocarcinoma. And here comes the hypothesis: which is the actual driver? So is it the BRCA or is it the KRAS? So here is where what we did is, because foundation one also does, the CGP also captures the loss of heterozygosity or the HRD score, we are trying to see whether the HRD is high. If the HRD or the LOH score is high, it means that the BRCA is the driver. Whereas if the HRD is negative, then the BRCA is not the driver, it is a KRAS that is the driver. So it is these kind of information that one can really get from a detailed look into the comprehensive genomic profiling. So with the shortage of time, I had to rush through a few of the cases, and I thank you all for your patience. And I'll be very happy to answer any questions if there are.
Dr. Arun, this was indeed a very, very informative presentation, and really amazed to see how to look in between the lines, and this is truly amazing. So 2-3 questions for you. So when there are multiple mutations in a single tumor, so how do we determine that this is a driver one? So this is sometimes a very, very important question. Secondly, once you find VAF of more than 50%, so it is especially true for BRCA only, or it is true for others also, that there can be a potential germline mutation in that? And then the third question, how do you reclassify the variant of unknown significance? So 3 questions we have for you.
Sure, doctor. So thank you for the questions. I'll answer one by one. Number one is, how do you identify the real driver? So that one can very easily see by, number one, we have to see the tumor type and the mutation that is there with that. So, and the way to classify the driver is to see the variant allele fraction. Suppose, hypothetically, let me say, there is a case of glioma with both BRCA as well as, or some case which has BRCA as well as EGFR mutation. If the BRCA mutation has a variant allele fraction of, say, 75% and EGFR has a VAF of 5%, it is the BRCA that is really driving the tumor here. So the variant allele fraction kind of gives you some idea about which is the driver mutation there. And that also helps you in identifying which targeted therapy to look for or to first give. So if you have EGFR as well as ALK, and you have higher frequency of EGFR mutation, the VAF percentage, you target EGFR first, then the ALK, or or vice versa, depending on the VAF. Now, the second question is about the germline origin. Generally, any variant allele fraction of around 50% plus or minus 5%, I would say, standard deviation, could be suggestive of germline origin. But it's true for all the genes, but generally you don't find germline mutations in EGFR, for example. So it is pertaining more clinically relevant more if it is in genes like BRCA or RAD51 or MMR genes like MSH6 or PMS2, etc. So that's where you have a familial component to it, a germline component to it, and it is worthwhile to investigate further. You can do a simple Sanger sequencing from the blood of the individual for the particular variant. And if that mutation is picked up, it is definitely germline in nature. And the last question on reclassification of the variant, that is a very tricky thing because any variant classification happens based on the establishment of pathogenesis of the variant. Suppose you pick up a MSH2 variant and it has never been reported in the world. Even if it is clinically very significant, clinically very much correlating, unless you have a cellular study or some kind of a functional study to prove that it is pathogenic, one will not be able to classify it as a pathogenic variant. So one thing to do with the PARP inhibitor story or the HRD story is that the genes of HRR, if they are mutated and if at all it is a VUS, now you have a readily easily available functional assay, which is your HRD score. So if that is actually driving it and you have the HRD score positive, even if the variant classification is VUS, you have, if the HRD score is high, you have a kind of you can be convinced that you can go with the PARP inhibitor therapy.
So one more question, doctor. So with so many labs coming up and all of them, they are doing now NGS, every other lab is doing that. So how do you rely upon the quality of the lab? How do you see that the report is of good quality? So something to see in the report to tell you that it is a good quality lab we are dealing with?
Absolutely, doctor. So I myself have personally worked with a few labs in India. So number one, you have to look for the accreditation. Accreditation alone does not suffice, but proficiency testing. And then in the report, try to see the depth of sequencing, which they have done. Ideally for somatic, it should be 500x. Anything less than that might reduce the quality. There is a very good possibility of getting a false negative. And most importantly, look for clinical and analytical validation. Anything less than 1,000, 5,000 samples, that are 5,000 samples were used for validation, means that the assay is not very much validated. So that is something very important. So doing just a few hundred samples or tens of samples and saying that it is validated really makes no clinical or analytical sense to it.
So I think more than 5,000 samples, they are huge size. I don't know many of the labs, they are validating their report with the help of 5,000 samples.
Yes, that is the challenge. And that is why you come across a lot of errors in the report. That is why you come across many a times, wrong reporting, false negatives, false positives in the reports. And that is why it's the point I'm trying to make is it's not a biochemical test where analytical parameter alone is important. It's not an automated one. The real challenge with NGS is that it's not completely automated. You need a human intervention to interpret the data. I sequence my own sample. I'm a normal individual. I sequence my sample. I get 1 lakh variants. How do I make sense out of the 1 lakh variants? Although you have artificial intelligence and other things coming up, there is a human intervention required, and that's where validation plays a very, very crucial role.
Thank you so much, Dr. Arun. So we are getting short in time. It's pleasure talking to you. Thank you so much.
Thank you, doctor. Thank
so we'll move ahead to another session. This was an absolutely amazing session by Dr. Arun. The next session is by Dr. Praveen Jan, and he is a consultant and head of medical oncology in Akash Healthcare Hospital, Delhi. He will be talking about bringing precision to medicine to newly diagnosed ovarian cancer. Dr. Praveen, over to you.
Thank you, Manish. I'm not able to hear now. Probably I'll be able to share my screen. I hope my screen is visible.
Yes.
And I'm audible too.
Yes, Dr. Praveen.
Okay. So first of all, thanks, Manish, for giving me this opportunity. So my job here is to talk about HRD. So Dr. Arun has already spoken about so many things in molecular oncology. And then I'm here to speak on the clinical aspect of HRD. Is it the new BRCA, or is it something which is more than the BRCA? So to see the burden of ovarian cancer, we can see over here that almost close to 3 lakh patients, women, they are diagnosed with ovarian cancer every year. And this was the data of 2018. And out of these, 60% they were advanced disease, and 70% of these women, they will relapse within 3 years of first line treatment, and the 3 to 5 year the 5 year survival of these patients with advanced disease is close to 30 to 50%. So definitely it is an unmet need, and we need to improve upon the treatment to improve the outcome. And this is the exact natural course of ovarian cancer. So it is characterized by relapses and remissions. And we can see over here that the subsequent relapses, the platinum free interval, which is the time period between the last dose of platinum and the first relapse. So this platinum free interval, so this keeps on decreasing in the subsequent relapses. And there will be a time when the disease will be platinum resistant or refractory. This is the resistant disease, and these are the refractory disease. So at some point of time, the patient will have some intestinal obstruction and will succumb to the disease. So once the disease relapses, it is largely incurable. First line treatment for advanced ovarian cancer is the optimal setting to achieve a potential cure. So these are the different timelines. So where there had been paradigm shift in the treatment of ovarian cancer. Till 2003, the only treatment which was there was the chemotherapy, non-platinum based chemotherapy in 2003. So there came the era of platinum taxane based therapy, and which became the standard of care. Till 2011, so the chemotherapy alone was the standard of care. 2011, bevacizumab was approved on the basis of GOG 218 trial, which showed a median PFS advantage of close to 6 months. And there was no overall survival advantage with the addition of bevacizumab. So this was the first paradigm shift. The second paradigm shift came in 2018 when FDA approved PARP inhibitor in the first line maintenance setting on the basis of SOLO-1 trial. So which had selected only the BRCA mutated patients. So here the benefit of olaparib, a PARP inhibitor, was given only to those with BRCA mutation positive status. In 2019, on the basis of PAOLA-1 trial, so all comers, they were given, they were tried with the addition of olaparib to the standard of care chemotherapy plus bevacizumab regime, and it had shown that those patients who were HRD positive, so they had definite benefit in terms of PFS with the olaparib addition. So this was the third paradigm shift. So we will discuss all these things. So what is the mechanism of DNA repair? So we can see over here these inserts may be radiation, chemotherapy, reactive oxygen species, replication errors. So these leads to single-stranded breaks, and these single-stranded breaks in a normal scenario, these are rectified with the help of base excision repair pathway, and later on the PARP inhibitor. So this is very, very essential for this base excision repair pathway. So those single-stranded breaks which does not get repair with this single-stranded repair pathway, so these get converted into double-stranded breaks, and these are again repaired with the help of two kind of pathways. One is the error-free pathway, and one are the error-prone pathway. So the error-free pathway, so they are the homologous recombination pathway, and these are the genes which are important in this. These are BRCA1, BRCA2, RAD51, mRN complex, and ATM. And other two pathways, those are the non-homologous and joining pathway and MMEJ. So these are the error-prone pathway. So the whole physiology is that the tumor cells which have this BRCA1 or 2 mutation status, so they are not able to repair these double-stranded breaks. So if these cells, they are made PARP deficient also, so then these single-stranded break coming out of chemotherapy, radiation, or some other insults, they will not be repaired with the PARP inhibitor, and later on they will not be repaired with that double-stranded break repair pathway. So this will ultimately lead to cell death, and this is called synthetic lethality. So this is the concept which we have to understand. So coming to the frequency of HRD positive patients. So this was a trial which showed that HRD positivity is seen in approximately 48% of the patients, and more than 50% of the patients, they have either HRD or possibly HRD. and another 15% of the patient, they do not have the status of HRD. So these are HRD unknown. And so these HRD positive patients, they have included BRCA mutation either as a germline or a somatic mutation. Then there are other homologous recombination repair gene mutations like CDK12, then core RAD, then FA gene mutations, then altered HRR gene expression like BRCA1 promoter methylation or RAD51 promoter methylation, and there are other unidentified causes. So in totality, more than 50% of the patients, they have HRD, which we can detect with the genomic instability score, and it leads to genomic instability. So coming to here, so these are four kind of cells we can come across. The normal cell, they have intact homologous recombination repair pathway as well as the base excision repair pathway, so which leads to cell survival. Either of BRCA like homologous recombination deficiency or base excision repair deficiency alone, so they will not lead to cell death. But whenever there is combination of homologous recombination and base excision repair defects, so then it can lead to cell death. So this is the concept we use those cells which are deficient in BRCA or HRD. So they are deficient with the homologous recombination repair. And if we see, if we give PARP inhibitor in these patients, which leads to defect in the base excision repair pathway also, which leads to cell death or tumor cell death. So there are two kind of tests which are available to identify HRD. So one set of tests, they focus on looking at the cause of HRD. So these are the HRR genes test, gene mutation test, or BRCA gene mutation test. What they do is that they focus on the genomic changes that can cause defects in HRR pathway, and they assess the cause of HRD by looking for the loss of mutation of these key HRR genes. So another way to look at HRD is to look for the effect of HRD. And this is something genomic instability test, which is on the basis of these three type of things. So one is loss of heterozygosity, one is telomeric allelic imbalance, and one is large scale state transition. And with these three aberrations, three kind of aberrations, a genomic instability score is defined. So which, if it is more than 42, so then it is HRD positive, and if it is less than 42, so it is HRD negative. So these are the two ways of looking at HRD. And there comes the importance of looking at HRD rather, so to look at the effect of HRD rather than to look at the cause of HRD. We can see over here that 15% of the patient, they have blood where they have germline BRCA mutations. If we see, if we include the somatic mutation also with this, so then the 20% is the number which will get benefit out of olaparib. If we do HRR mutation testing, so we are including germline and somatic BRCA along with other HRR mutation, so the number comes out to 31%. And if we see the HRD testing with genomic instability score, so close to 50%, they will get the benefit out of PARP inhibitor. So there is incremental benefit of using this test, and the best test to use and to give PARP inhibitors to is on the basis of HRD. So ESMO guidelines also recommend HRD testing to identify most patients who will gain benefit out of PARP inhibitor. And we can see over here that germline BRCA mutations. So in first line, it is a good thing to recommend. Then tumor BRCA mutation, good. Then somatic BRCA mutation, again, good is the criteria. And if we see the genomic instability score, again, it is a good parameter to use PARP inhibitor in first line maintenance setting. So these are the validated method to detect HRD. So one is the tumor BRCA mutation, presence of BRCA mutation that gives HRD positive status. And the other thing is the genomic instability with the example of this is the myriad my choice genomic instability. And there are a lot of other assays which are available in Indian market right now, and you can use those also. And we have to see the, as pointed out by Dr. Arun, that we have to see the analytical validity of these assays also. And it is on the basis of these three kind of aberrations. So one is LOH, one is TAI, and one is the LSST. So these are these are the steps on the basis of which we will decide whether the patient is a candidate or not. So first step is to do a BRCA mutation status and HRD status, if whether it is a positive wild type or the mutated type. The step two is whether the patient is a candidate for bevacizumab or not. And the third is the clinical characteristics, platinum sensitivity beyond HRD status, because if the patient is not platinum sensitive, even if there is HRD positive status, then probably I'll not be very keen in using in the upfront setting. So coming to the clinical trial data of olaparib maintenance. So there are two trials, Solo 1 and Paula 1. So we have 4 or 5 PARP inhibitors which are being used in these settings. But as of now, the maximum approvals, so they are for olaparib, and the maximum data and maximum experience is also with the olaparib. So we can see over here that Solo 1 trial, they had selected newly diagnosed advanced ovarian cancer patient with any surgical outcome, and they had selected only BRCA mutation positive status patient. And these patients were either received surgery, upfront debulking surgery or interval debulking surgery. And those patients who had response to platinum-based chemotherapy, they were given olaparib maintenance. So the second trial was the Paula 1 trial, which was for the all comers. So they had not selected on the basis of the biomarkers, but they had pre-specified subset analysis on the basis of tumor BRCA mutation status, then HRD status. So they had done the pre-specified subset analysis. Here, the surgical outcome also did not differed. So either the patient had complete cytoreduction or incomplete cytoreduction. All were candidate for this trial. And in this trial, bevacizumab was used in all the patients. So coming to Solo 1 trial, they had selected newly diagnosed FIGO stage 3 or 4, high-grade serous or endometrioid ovarian PPC or fallopian tube cancer. They had selected the patient with germline or tumor somatic BRCA mutation positive status. And sorry, these patients were randomized into 2:1 fashion to olaparib vis-a-vis placebo. And the total duration of the treatment was 2 years. And if the patient was having benefit from the olaparib when patient was not having any toxicity, these patients could have been continued on olaparib till progression as per the PI discretion. So the primary endpoint of this trial was the investigator assessed PFS, and the secondary endpoints were PFS using BICR, then PFS2, then overall survival, then time from randomization to first subsequent therapy or death. And similarly, they had also looked at the time from randomization to second subsequent therapy or death. And they had also looked at the HRQOL on the basis of FACT-OTOI scores. So we can see over here, these are the Kaplan-Meier curves showing the PFS advantage. We can see over here, initially only the graph separated. And we can see over here that the median PFS was 56 months with the olaparib and 13.8 months with the placebo, with a hazard ratio of 0.33. And we can see over here at the time, 2 years was the time when olaparib was discontinued. Even after discontinuing, the benefit was persisting. And we can see over here that the graph remains separated throughout. At that 5-year follow-up, so 48% of the patients, they were still on olaparib as compared to 21% who were on placebo. So they also had looked at the PFS2 time to second subsequent treatment also. And what they had seen was that the hazard ratio was 0.46 in these two endpoints. And this was in favor of olaparib. So the safety profile we can see over here. Yes, the safety profile was slightly worse with the olaparib, but these were mild grade 1 or grade 2 side effects most of the patients, and these were mainly nausea, fatigue, and anemia, which were more with the olaparib. And these were easily manageable. Yes, there was dose reduction, dose interruptions because of the anemia, but later on these were easily manageable. So the next trial was the Paula trial, who had selected all those patients with stage 3, 4 high-grade ovarian cancer, either serous or endometrioid, with surgery upfront or interval debulking surgery, and the patient should have received the platinum taxane-based chemotherapy, and there should be either no evidence of disease, CR or PR status post chemotherapy. So these patients were randomized into 2:1 fashion with olaparib plus bevacizumab maintenance for 2 years, or placebo for 2 years plus bevacizumab maintenance for 15 months. And the endpoint were PFS, and the secondary endpoint were similar to the Solo 1 trial. So the characteristic of the peculiar point about this trial was that they had taken the representative first line patient population, because they had included all the patients irrespective of the biomarker status, irrespective of the surgical outcomes, and irrespective of the platinum responses. And they had a pre-planned subgroup analysis according to the tumor BRCA mutation status, HRD status, and HRR mutation status. And it was the only phase 3 trial of a PARP inhibitor with an active standard of care comparator, which was bevacizumab. So we can see over here that the PFS, so the curve separated early on and they remained separated throughout. And this was in the overall population. And we can see over here that there was a delta of PFS of 6 months in favor of olaparib plus bevacizumab, and the hazard ratio was 0.59. So we can see the subgroup analysis over here, that all the subgroup, they had benefit with the olaparib. We can also see over here those patients who had debulking surgery with no residual macroscopic disease also had benefit, and those patients who had debulking surgery with residual macroscopic disease, so they also had benefit. So irrespective of the surgical outcomes or the timing of surgery, the benefit was there. So they also looked at the HRD positive status. So we can see over here that 48% of the patients, they were HRD positive, out of which 29% were the tumor BRCA mutation positive, and the rest of them 19% were those with genomic instability score more than equal to 42, excluding tumor BRCA mutation positive status. And 18% had HRD unknown, and 34% had HRD negative status. So we can see over here that the PFS in intention to treat population was, the delta was 5.5 months and the hazard ratio was 0.59. If we see the tumor BRCA mutation positive status or HRD positive, including tumor BRCA mutation positive patients, so it was, so the benefit was persisting, and the PFS was 0.31, hazard ratio was 0.31 and 0.33. But here in HRD negative patients, so the benefit was not there, and the hazard ratio was 0.92. So this was the pre-specified subgroup analysis showing substantial PFS benefit in HRD positive patients. So the median PFS was 37.2 months in the HRD positive status, HRD positive patients, and 17.7 months in the HRD with the placebo arm. Sorry, 1 second. So if we look at the HRD positive patients without tumor BRCA mutation positive, so the median PFS was 28.1 month in the olaparib arm, vis-a-vis 16.6 month in the placebo arm, and the hazard ratio was 0.43. So these patients who were HRD positive, tumor BRCA negative, they also had good amount of advantage with the olaparib. If we see 1 second, please. So if we see those patients who were non-tumor BRCA, so this we have already. 1 second, it is happening. So so this is time to second disease PFS2. So we can see over here that the PFS2 median was 36.5 months in the olaparib arm and 32.6 months in the placebo arm. So it definitely reduced the risk of second progression in intention to treat population. So these were the PFS2 curves. One was in the HRD positive, including tumor BRCA mutation positive status, and we can see over here that the hazard ratio was 0.56. And those patients with HRD positive status, excluding tumor BRCA mutation positivity, so those had a HR of 0.6 in favor of olaparib. And those patients with HRD negative or unknown status, so there was no benefit of adding olaparib to the bevacizumab maintenance. So they also looked at the PFS and PFS2 improvement in HRD positive patients. So the PFS2 was the date of from the date of randomization to the failure on the subsequent therapy. So we can see over here that the PFS in HRD positive population, and they also try to correlate it with the clinical higher risk or lower risk status. So clinical higher risk for those patients who initially were treated with cytoreductive surgery with gross macroscopic disease, and lower risk were rest of the patients. So what they had seen was that the benefit was persistent in both the groups, and the benefit was literally more with the lower risk subset as compared to the higher risk one. And the similar was the curve for PFS2 in HRD positive population. So they also try to look according to the stage of the patient, and stage 3 versus stage 4, the benefit of olaparib was persistent in both in terms of PFS and PFS2. And we can see over here that the time to second subsequent therapy also improved with addition of olaparib to bevacizumab with a hazard ratio of 0.78. If we see the response rates, so the response rates, they were better in olaparib group in the overall population, in the BRCA mutated population, in the HRD positive tumor BRCA positive status, and HRD positive non-BRCA mutation positive status. In all these 4 subgroups, the overall response rate were significantly better with olaparib addition. However, if we see HRD negative patients, so there was no advantage in terms of overall response rates. So all the adverse events, the total number of adverse events, all grade AEs, grade more than equal to 3 AEs, they were comparable in olaparib versus no olaparib group. However, there were more dose interruptions, dose reductions, and the treatment discontinuation in the olaparib arm as compared to placebo arm. But these dose interruption and reduction, most of the times they were easily manageable. So nausea, fatigue, anemia, these were significantly more with the olaparib as compared to no olaparib group. So another concern is regarding the incidence of MDS, AML, and other malignancies. So in the primary analysis and final analysis, so there was not much of difference between the initial and primary and final analysis. And we can see over here that the HRQOL parameters were also matched in both the groups. So the key takeaway messages are that HRD SCAR test is a new BRCA test, and SOLO-1 trial has shown that the maintenance olaparib showed 67% reduction in risk of disease progression or death. PAOLA-1 in HRD positive patients showed a significant improvement in PFS with addition of olaparib to bevacizumab, and there was significant improvement of PFS1 and PFS2 with addition of olaparib to bevacizumab. And HRR and HRD are not interchangeable and should not be considered as substitute for each other in clinical practice for first line maintenance. With this, I would like to end my talk. Thank you.
Dr. Praveen, thank you. So that was an enlightening talk about HRD and the genomic scoring. I think you have already changed your practice, right? So
yeah,
HRD is the way to go. So how do you see the HRD scores that have been developed in India, and are you convinced with the kind of performance these HRDs they are doing with your patients? So can you share your experience about that?
so I have used the HRD scoring from Strand Life Sciences in 4 of my patients. In fact, 5 of my patients, and 4 out of 5, they came out to be HRD positive. So 2 were germline BRCA mutation positive, and 2 were like HRD positive tumor germline BRCA negative. So out of these 4 patients, I have started olaparib in all these 4 patients. So what I have seen is that these patients, so 3 of these patients are in the first line maintenance, and 1 patient is in post 2 lines of treatment. So I couldn't assess the response in these 3 patients in the first line maintenance, because they are still on this therapy, and since last 4 to 6 months they are on this therapy. So I do not have a long-term data for these 3 patients. But the 4th patient, which was HRD positive, but the tumor BRCA status or tumor BRCA status was not was negative. So that patient was a because in that patient we could have seen the responses with CA-125 or imaging. So because that was a relapse patient, so that patient had response to this. So I'm not sure what is other people experience, but this was one patient who were BRCA negative and HRD positive who had response with olaparib.
Thank you so much, Dr. Praveen. So in the interest of time, I think
I just want to ask one question, if anybody can answer those, because this I couldn't get anywhere. So have anyone experienced that those patients who have germline BRCA mutation, so they have more side effect with PARP inhibitor as compared to those with only tumor BRCA mutation positive status or tumor HRD positive status?
I think Dr. Akhil Kapoor is here. Dr. Akhil, can you take up this question?
Yeah. So now we have experience of treating more than 50 to 70 patients with olaparib or rucaparib. So definitely the toxicities are there, but I don't think this is matching with the presence of a mutation. Definitely we know the efficacy will be different in these patients, but the toxicity per se, in my experience, I found even when the patient doesn't have mutation, when we use in the 3rd line or 4th line, when other drugs have been exhausted, because olaparib is approved in that setting, we have not found too much of difference in terms of toxicity. The toxicities remain the same. We have learned how to manage the toxicity with experience and time. In my experience, I don't find the toxicity to be different as per the BRCA mutation.
But logically, if we see, so those cells, like if the BRCA mutation is positive only in the tumor cell, so then tumor cell only is using the this HRR defect is there only in tumor cell. If so, then if you are blocking the PARP with PARP inhibitor base excision repair pathway also, so then these will be the cell which will be having synthetic lethality. So if you talk about the germline BRCA mutation positive status, almost all the cells, they will be using BRCA as a way to repair the PARP inhibitor induced double-stranded breaks. So logically, the toxicity should be more with this. I don't know, because I couldn't get any analysis of this sort, whether the toxicity is more in those with germline versus tumor BRCA mutation positive.
So actually, most of the patients where we get tumor BRCA mutation, we actually test for germline, and most of our patients come germline positive itself. So definitely the subgroup of the patient where only tumor BRCA is positive and germline BRCA is negative, it's somewhat smaller actually. As we know, 30% patients where that it is coming as BRCA mutated, 20% will be germline, rest 10% will be only somatic. But in real practice, we are doing more of germline testing actually. We know that might be the confounding factor which limits us this experience.
Thank you.
So in the interest of time, I would like to introduce our next speaker. And this is a session on ESCO 2020 updates on rucaparib in particular. And Dr. Akhil Kapoor is assistant professor in prestigious Tata Memorial Hospital in Medical Oncology Department, Varanasi. He will be taking us through the updates on rucaparib in ESCO 2022. Please, Dr. Akhil Kapoor.
Thank you. Thank you. So I'll be sharing my slides. So I've been given the task of sharing the ESCO updates on the rucaparib. The slides have been a session sponsored by Zydus. These are my disclaimers. So we'll move ahead. So Athena trial, yes, this was a very, very long awaited trial, and this is very important study for our real practice, because we know when a drug with a generic molecule becomes available, we try to get data which is by which we can justify the use of a molecule which is available to a larger number of patients. And with the availability of this data, it is definitely much become more easier to use this drug now. So this is a randomized trial, phase 3, evaluating rucaparib monotherapy versus placebo's maintained treatment following response to first-line platinum-based chemotherapy in ovarian cancer. And these are the backgrounds which I have just covered already. So this was used in ENGOT member countries, GOG, and other participating countries. So multiple countries were part of this trial. So if we see the genetic biomarker status of the enrolled patients, there was close to 540 patients were enrolled, 50% were HRD negative, 25% were HRD positive, BRCA wild type, and 25% were BRCA mutant. So this is a very good pie chart with very good distribution, 50, 25, 25. So easy to remember. And this has been done on the Foundation 1 CDX by Foundation Medicine. So this is a very well established lab from which is has got high quality, so it is very good. And this that means at least 50% patients are HRD positive, which includes 25% having BRCA mutant and rest 25 BRCA wild type but HRD positive. So in this study, actually there were a nivolumab arm as well, where rucaparib was administered along with nivolumab, and under arm B, around 400 patients received rucaparib alone. In arm C, it was nivolumab alone, and arm D, it was both were placebos. So we'll see the study analysis of Athena mono and Athena combo. The Athena mono, that means rucaparib versus placebo. On Athena combo was Athena rucaparib plus nivo versus rucaparib alone. So these are these patients of stage 3-4 high-grade epithelial ovarian or primary peritoneal tumor enrolled. Patients had completed frontline platinum doublet chemotherapy and surgery. And the stratification factor was versus BRCA mutation versus BRCA wild type with high LOH, BRCA wild type with low LOH, and BRCA wild type with LOH intermediate. So loss of heterozygosity was taken up, and this was given a high importance. And this is what we have already discussed. Patients were continued under treatment for 24 months or more till progression or till toxicities, and then stopped after 2 years. So this is the baseline characteristics. It was, since it is a very well conducted randomized trial, patients were balanced in both the arm, HRD population group versus intention to treat population group. Significant proportion of the patients were PS0. However, in real setting, most of our patients are PS1 to 2 at presentation. Definitely in a trial setting and in Western setting, more patients are in the PS0 situation, which is not very common in the real world scenario. But yes, we know the benefit will be there in both PS0, PS1, and PS2. The quantum might be somewhat different. And definitely, as happens in most of the scenarios, around 80% patients in all the patients were around epithelial ovarian cancer, and 10 to 11% are fallopian tube cancer, and rest 5 to 6% are primary peritoneal cancer. So in our setting also, we find 85 to 90% to have high-grade serous ovary, and 5 to 10% being primary peritoneal or fallopian tube cancer. Per se, primary fallopian tube cancer, usually it is difficult to identify because usually the patient have a significant disease burden, and the site of origin is difficult in especially in stage 4 patients. If we see the HRD positive group, this is what I had just highlighted. Most of the patients were HRD BRCA mutated, around 50%, and rest were BRCA wild type but LOH. So it is. And if we see the data of Athena mono, that is median PFS in HRD positive patients population, if you can see the stark difference in the outcomes at 1 year, 47% versus 73.8% progression-free survival, and this was persisting at 2 years, 35% versus 55%. So a significant 20 to 25% improvement in PFS at 2 years. This is what we want to look at. If we see, this was investigator-initiated study, and this was the site blinded independent review. If we see the all-comer patients studied, it is again at 2 years 25% versus 45%, and it is the value hazard ratio is coming to 0.47. So this is another study where we need to understand the hazard ratio is going below 0.5. Hazard ratio below 0.5 means a study where the treatment is causing a very extraordinary difference in the outcomes, and this is study is one of those, hazard ratio of less than 0.5. If we see the various exploratory subgroup analysis, which are very important to understand, if the HRD positive with BRCA mutated and BRCA wild type with LOH high, this is what we wanted to know. In here, if you would like to see, the difference is very, very stark in BRCA mutant. We all know this. The efficacy is, we all were well aware in this patient group, it will be the maximum benefit, hazard ratio is 0.4. But if we see BRCA wild type with LOH hybrid, again, hazard ratio is not so bad. It is hazard ratio 0.58. So the most of the time the drugs get approved with hazard ratio below 0.8, and here it is 0.58, close to 5 only, 0.5 only. Yes, in BRCA mutant, it is extraordinarily good, 0.4, but it is very good. If we see the HRD negative subgroup also, the hazard ratio 0.65, but if we see the median, it is not so encouraging, but it is worth considering this difference in oncology as well, because a drug get approved most of the time, even when the difference is 1 to 2 months also, but it can cause significant improvement in the quality of life. So HRD negative, 9 versus 12 months, the difference is not so stark in terms of separation of the curve, but still hazard ratio is 0.65. It can be considered in this HRD negative as well. But yes, the quantum of benefit, which we know from the time of niraparib also, niraparib is also approved regardless of the treatment HRD test or BRCA test. Similarly, we are finding difference in the benefit is different quantum wise for the different subgroups. This is the similar groups were found on the blinded independent review. So it is demonstrating benefit irrespective of the BRCA mutation or HRD sensitivity. So all the groups, you can see the curve is toward the forest plot is toward the left in favor of rucaparib. That makes us sure that yes, this drug is going to benefit a large number of the patient. Almost all the patients who get enrolled in this drug get treated with drug will get benefit with rucaparib. So yes, it is beneficial. If we see the confirmed overall response rates in HRD positive group, you can see it is close to 60%. Intention to treat, it is close to 50%. And duration of response, yes, it is crossing 20 months in most of the patients. So this is an important point. Yes, the toxicities, we have now experience with olaparib and rucaparib, a large number of experience at our center as well. And our data of our more than 50% patient, 50 patient is under preparation and publication. Yes, PARP inhibitors are somewhat toxic, but it can be managed well. The toxicities can be managed by maintaining the doses in a very intelligent way. You can reduce the dose, you can check the CBC and LFT timely. So never ever when you start the treatment initially for 3 to 4 months, these are more critical time. It is should be aware, and we should be very careful in this time. Don't give a prescription for continuous 2 months, 3 months, because this patient can cause significant amount of anemia, thrombocytopenia. So at least at 10 to 15 days initially, do CBC and LFT so that transaminitis and anemia, thrombocytopenia can be taken care of. Other important side effects include diarrhea, abdominal pain, and nausea. But it is very important that the problem of anemia, thrombocytopenia, and transaminitis, these three are the most important problems. Others are usually well managed if these are well controlled. These are the lab parameter. Yes, the initial part you need to, as I told, the initial first 3 months are very crucial to maintain the toxicities. After that, it becomes stabilized, and you can see this is maintained very standard, very straight curve. So yes, and dose intensity. If we see what was the dose intensity level, so 3 dose levels were there around 500 milligram BD at dose level -1. -2 was 400, -300 milligram BD. In fact, in real practice, I think 600 milligram BD, I'm not very comfortable at starting this dose. However, it is personal preference for the physician what dose is to be selected. But there are options to start at lower dose and later titrating it up. Also, there is an option starting at higher dose and titrating it down with the toxicity. It is as per the physician experience. But if we see the data around in 50% patient, there was requirement in the dose adjustment. But yes, a lot of patients can continue with full dose in the Western patients. We need to see our own data so that we need to understand what dose is best tolerated for our patients, and this Western data cannot be used for generalizability on our patients. If we see the FACT scores, The factor score is a score to measure physical, social, familial, functional well-being, and it is preserved as same as placebo. So this gives us more confidence that if the toxicities can be managed well, you are able to preserve the quality of life of these patients. So this is important. So to conclude from this data, it is first-line maintenance data significantly improves progression-free survival irrespective of HID status. Yes, quantum benefit will be different for different subgroups. And patients with measurable disease at baseline have further tumor reduction with rucaparib. So, and rucaparib safety profile is consistent with prior studies, and we are now well aware of the toxicities and how to manage them. OS is immature at present because only 25% event of death has occurred till now, and we need to await further data for OS. But definitely, any drug which is causing hazard ratio of less than 0.5 is definitely going to have significant impact on the oral survival as well. So moving further ahead, this is the data of open label study where bev, atezo, rucaparib were utilized. Patients received combination of rucaparib, bevacizumab, and atezolizumab. This was a 30 patient subgroup analysis with primary goal of overall response rate. And this is a patient for recurrent endometrial cancer, which are not available to curative treatment or surgery or radiation after 1 or 2 lines of therapy were eligible regardless of the histology. So yes, this is studies for recurrent endometrial cancer, which have been received 1 or 2 lines of treatment. So the CR rates is around 4%. That means one patient had CR, partial response was seen in 40%, stable disease in 57%. PFS is around 5.3 months. So some amount of responses. This combination may be safely used, but definitely we'll need to see further data in the phase 2 and phase 3 studies. This is an initial phase 2 data. So there's data of pembro plus lenvatinib already in the endometrial cancer, and we are utilizing that combination also in selected patients. So this data, yes, it can be considered in some amount of patients, but yes, we need to await more data actually for utilizing in our practice. And if we see the data of the post hoc analysis of the Ariel 3 data, where the platinum sensitive patients were not associated with homologous recombination deficiency, it was performed to assess the efficacy of rucaparib maintenance in a subset analysis patients who had responded to platinum based treatment but were HRD negative. So patients were randomized to receive rucaparib to 600 milligram BD versus placebo 2:1 ratio, 100 plus patient in arm of rucaparib and around 50% in arm of placebo. And yes, you see the patients had received prior bevacizumab in around a large number of the patients and prior number of platinum treatment as well. In all these groups, the patients had hazard ratio of 0.6. The patient who had response to last platinum, yes, the hazard ratio is to the tune of 0.44. So yes, it is important. Platinum response itself confirms sensitivity to PARP inhibitor. This we all know from a long time, and we should take this question in very important. So yes, so in maintenance treatment in platinum sensitive recurrent ovarian cancer, it is clear that even patients who are HRD negative will continue to benefit from the drug rucaparib. So in recurrent setting, in fact, you do not need to test for BRCA for utilizing this drug. But yes, if BRCA has been not tested as a germline testing, it should be tested because it is for the implications for family. It is important. So we try to have a dedicated genetic clinic in our hospital, and we have started the same with great enthusiasm. So maintenance therapy will rucaparib lower the risk of progression in ovarian cancer patients, irrespective of presence of either BRCA mutation or HRD in patients who responded to platinum-based treatment in recurrent setting. This is the Atlantis study, metastatic urothelial cancer patients with DNA repair deficiency. So Atlantis is a multi-arm study. There are multiple arms of this phase 2 data basket trial. Actually, these patients included urothelial cancer who were biomarker positive for DNA repair deficiency. The patients had achieved either stable disease, partial response, or CR on first-time platinum-based treatment. They were randomized to receive rucaparib maintenance versus placebo. This actually placebo arm was later dropped when avelumab became standard of care in these patients. But yes, this is the arm which was there. So primary endpoint was PFS and second endpoint was overall survival. And if we see out of 279 patients, 248 patients were screened, and if we see the baseline characteristics, it was yes well matched between the two arms. There was some numerical improvement because this is only 20 patients in the two groups. and there was some improvement in terms of PFS with maintenance rucaparib versus placebo. So there was a confirmed objective response rate or partial response in one patient in rucaparib, but others there was mostly stable disease and progression free. So hazard ratios though reaching 0.53, but the problem was that this was a small subgroup, small groups which was analyzed. So this is considered as a exploratory option, not a standard of care option till now. So the Atlantis trial, the safety is again similar, median duration, no treatment related deaths were observed. So this study, the investigator concluded safety, this patient were found to have somewhat improved PFS data. It was 15 weeks versus 35 weeks, but this is based on only around 40 patients. This was not statistically significant, and concluded that results support further study of PARP inhibitor in biomarker selected patient. Yes, so in biomarker selected patient, the further study is needed to consider rucaparib maintenance in the treatment. So with this, I stop here and would like to take any questions if there are.
Akhil sir, kindly check your inbox. Chat box question has come.
Okay, okay. So should I take the question directly?
Dr. Akhil, so Dr. Rajat have two questions. So one is, are you comfortable with 4:1 randomization in this clinical trial? And second question is whether you will be using, so this is a question from myself also, whether you are comfortable using Nupar for oral patients who are HRD negative also, so you don't find much difference. And one important question, so do we now get away with the bevacizumab in this line? Is the Nuparp and olaparib only option for our patient, or we still have some option for bevacizumab in this setting?
So first question about the 4:1 randomization. If the trial is enough powered for so much of arms, definitely it is fine for me. So 4:1 randomization, I will be comfortable if the statistical analysis is powered enough to answer that. Because if we are doing 4:1 randomization, there will be different arms and there will be different subgroups which needs to analyze. But this is all the work of statistics, and we can clearly see the difference in the survival curves, which is a clinician can easily interpret. The patients are getting benefit. This is very clear. How much amount of benefit? This is also clear. In the different subgroups, the benefit, the quantum of benefit is different. So if I have to use the group where the patient is having maximum benefit, yes, I will be pushing the patient to receive the same. But for example, if we take the HRD negative group in the upfront setting, the quantum benefit is small. Median is prolonged from 9 months to 12 months. So in this subgroup, I might not be too much comfortable. And also in such cases, what we can do is actually we can explain the patient, this is the limited benefit option, and the patient might select, because the difference which might be less for us might be more for the patient perspective, and the patient has to take the final decision. But yes, our enthusiasm will decay when the patient are HRD negative, especially in the first line maintenance setting. In second line maintenance, yes, hazard ratio is very good. So in the second line, recurrent setting, platinum sensitive, patient receive platinum, you can definitely utilize rucaparib irrespective of testing very comfortably, and we are very sure that it is one of the best treatment in that scenario. In with what is the status of bevacizumab now? So bevacizumab has a different role, which is completely different from PARP inhibitor actually. So if you have to use one of them, it is definitely PARP inhibitor. But definitely we know some patients have too much amount of ascites or pleural effusion at the baseline. These patients actually require some bevacizumab as well, because PARP inhibitor is working on a different pathway, but bevacizumab is acting by VGF mechanism, by which the amount of fluid secretion and endothelial mechanism is downregulated. So if patient had significant amount of ascites or pleural effusion at the baseline, I would be happy to use combination in those patients, but it is not for all patients, and or not all patients can tolerate the toxicity as well. So selected patient can utilize both. The role of bevacizumab has definitely decreased somewhat because of availability of some better options, but it has not completely gone.
So I agree with you, Dr. Akhil, and I think bevacizumab still has a role to play, at least in those patients who are inadequately cytoreduced or have heavy burden of the disease. In particular, if you are using bevacizumab in this line, Will you combine it with rucaparib or olaparib? So we don't have data for rucaparib at the moment in combination with.
So, so if I have to ever combine with rucaparib plus bevacizumab, I will take a written informed consent from the patient. That patient has been explained that this is not a standard option, but it can be considered if the patient is not affordable for olaparib in very selected group of the patient. So this has to be taken in a very informed consent. So because it has medical legal issues.
So I think our flow chart goes like this. Our patient undergoes a cytoreduction followed by chemotherapy in form of paclitaxel and carboplatin, and we are doing HRD for all our patients now. And if they have HRD positivity, we go for rucaparib. If they have HRD negativity and a heavy burden of disease, I think olaparib plus bevacizumab is an option. And if HRD is negative and the disease was adequately cytoreduced and there was no residual disease, I think the observation makes sense in these patients. Is it what we understand now?
Yes, this is a nice generalization, and this is definitely one of the best possible algorithm for now.
Thank you so much, Dr. Akhil. Dr. Rajat, do you have any questions?
Now I think very well summarized. I know how the algorithm looks as of now. We'll wait for further OS data to mature so that we can, and maybe a randomized study between BEV, PARP inhibitors, maybe that can also be there in future.
I think till the time we have HRD positivity, our patient should not receive rucaparib because rucaparib has and olaparib also have a lot of toxicity, quality of life issues. We don't have OS data for first line maintenance for these patients. If ever, yes, the data for overall survival also comes, then probably I will be happy offering my patients rucaparib in first line maintenance, even if they are HRD negative.
Completely agree with you, Dr. Manish.
Thank you so much, Dr. Akhil. So the next session is on FASCO. We will be. Can you help me share my screen, Geetika? I'm not able to share my screen.
Yeah, sure, sir.
Yes, sir, you can.
Okay. So this is the session we will be discussing upon the fixed drug combination of trastuzumab plus pertuzumab. Session is sponsored by Roche, and we'll be discussing on the transform the journey for your HER2 positive breast cancer patient. So pertuzumab and trastuzumab, they have transformed the treatment landscape for HER2 positive breast cancer. So in all the settings, whether it is neoadjuvant setting, whether it is adjuvant setting, or in the metastatic setting, the combination has the role. So it has clearly a beneficial drug over the trastuzumab alone when we give pertuzumab plus trastuzumab combination. So in Neosphere study, we can see that there is clear advantage that patient will have plenty of PCR rates, and these PCR rates can go up to 60–70%. Similarly, in the adjuvant setting, if the patient, they have been operated upon without receiving any neoadjuvant chemo plus pertuzumab plus trastuzumab, these patients have advantage if they have node positivity or a large tumor burden. Similarly, in the metastatic setting, upfront use of trastuzumab plus pertuzumab has the overall survival advantage, and you can see here that the survival advantage is to the tune of 56.5 months versus 40.8 months. So this is an approved drug combination, and this is recognized by the international guidelines, NCCN, ESMO, and all over the world. So this is a nice flowchart which explains how to treat our HER2 positive patients. If patients have less than 2 centimeters of the disease, that is clinical T1, then the option comes that these patients may just directly go to the surgery. After surgery, if you find that there is no positive disease, these patients should receive pertuzumab plus trastuzumab combination, total of 18 cycles. If there is no node positivity, paclitaxel plus trastuzumab is option for 18 cycles. Similarly, if the tumor size is more than 2 centimeters or there is node positivity, the tumor burden is high, these patients should receive at least 4 to 6 cycles of pertuzumab, trastuzumab plus chemotherapy, followed by surgery, which can result in PCR. And if there is a PCR, we should have 18. If we have PCR for this patient, these patients should receive at least 18 cycles total of pertuzumab plus trastuzumab. But if in case they have residual disease, 14 cycles of TDM1 should be given to these patients. But the IV infusion of pertuzumab and trastuzumab comes with a lot of challenges. They can have problems in the healthcare system where plenty of patients are in waiting. The long infusion times and observation times are important in the infusion when we give it at clinic or hospital. At least 30 to 60 minutes for pertuzumab is needed, followed by 30 to 60 minutes of observation. And for trastuzumab, it is 30 to 90 minutes, followed by 2 to 6 hours of observation for the maintenance and the loading doses respectively. So long infusion time and observation time is one of the challenge. Second challenge of improving resource utilization. So IV preparation takes a longer time than subcutaneous preparation, and it requires more of resources as compared to the subcutaneous preparation. Third is the thing I think is the most important thing. You need to have the placement of maintenance indwelling catheters. So many of the indwelling catheters, they can lead to infections, they can lead to thrombosis, discomfort, and a sense of fear to the patients. So this is, I think, the third one is the most important problem which we all ever face when in our patients who receive prolonged number of cycles with pertuzumab and trastuzumab. Then challenge of venous access in some of our patients. Establishing IV access can be particularly problematic when patients have received plenty number of cycles of chemotherapy, having multiple venipuncture and thrombophlebitis. So FASCO is first of its type formulation, which is a single combination of pertuzumab plus trastuzumab, and this is presented in a vial for subcutaneous injection. It contains same antibodies as approved for IV preparation of pertuzumab and trastuzumab, but has different route of administration. The novel combination here is recombinant human hyaluronidase. So this is the recombinant hyaluronidase because of which we are able to inject our patients 15 ml of the total dose or 10 ml of the maintenance dose for our patients. So giving a 1 ml or 2 ml injection in a subcutaneous manner is a problematic thing. But with the advent of this RHUPH20, this is not a problem anymore. So it is ready to use fixed dose formulation administered by subcutaneous route in the thigh, and it approximately takes 5 to 8 minutes. So what is the mechanism of action? These are the two basic antibodies which we have, pertuzumab and trastuzumab. They are fixed dose combination which is administered subcutaneously, and primarily it is combined with the recombinant human hyaluronidase. So how does this work? So hyaluronidase is an endoglycosidase which is used to increase the dispersion and absorption of the co-administered drug when it is administered subcutaneously. So this is the layer of the skin. The subcutaneous layer contains the matrix of the hyaluron fibers and the collagen tissue, which limits the subcutaneous administration to the volume of less than 1 ml. So you cannot administer 1 to 2 ml of the drug in this subcutaneous space because of the presence of these fibers, collagen fibers and hyaluron fibers. But the addition of this recombinant human hyaluronidase to the FASGO, it temporarily and locally degrades this layer. And when you degrade this layer, there is no change in the structure providing the macromolecule. The degradation of the hyaluron is resulting in the temporary increase in the local subcutaneous dispersion area, and it enables the large volume of the fluid to be administered. And the beauty of this thing is that this architecture can be reformed within 1 to 2 days due to the rapid clearance of this drug and the fast hyaluron turnover. The formulation with this drug allows for the subcutaneous administration in the large volume, that is 10 to 15 ml of the drug we can easily administer with the combination. So this is how it works. So you can see here that this is the bolus injection which has been given without RHUPH20, and you can see that a bump has arisen here. But this is immediately post transfusion of the 10 ml of IgG solution, which is containing RHUP pH 20. So you don't find any bump here when you administer such a large amount of drug in the subcutaneous space. So then the important question comes to our mind whether it has the same pharmacokinetics and efficacy as that of IV preparation of pertuzumab and trastuzumab. So the Roche has this FASCO clinical development program, and the finding and the confirmatory dose for pertuzumab within FASCO was done in phase 1B trial, and this was BO 30185 clinical trial. It was completed in May 2018, and the recommended doses for loading are 1200 milligram of pertuzumab and 600 milligram of trastuzumab, and this should be followed by maintenance dose of 600 milligram pertuzumab and 600 milligram of trastuzumab, which is a fixed dose combination. So the pharmacokinetics, efficacy, safety, and preference, they were tested in SABCS 2019, and another clinical trial, FASCA. This is phase 2 trial in early breast cancer. This is ongoing and presented at ASCO 2020. So this is first phase B dose finding study for pertuzumab, and this was BO 30185. Once the dose of pertuzumab was found out, the patients, they were divided into 3 cohorts. One cohort received the pertuzumab separately and trastuzumab separately, the subcutaneous preparation. Another cohort received pertuzumab and Herceptin mixture that was given to the another cohort of 20 patients. And the third cohort, that is cohort C, received the fixed drug combination FASCO, that is trastuzumab and pertuzumab with a fixed dose combination. So the summary of this clinical trial was that the loading dose came out to be around 1200 milligram pertuzumab subcutaneous, and the maintenance dose came out to be 600 milligram pertuzumab subcutaneous to be used in this fixed dose combination FASCO. The PK study in the healthy male volunteer in the patient with early breast cancer predicted these doses will be resulting in the equivalent of the pertuzumab when they are given in the IV preparation, that is 840 milligram of pertuzumab in the loading preparation and 420 in the maintenance setting. The dose finding processes used to find the subcutaneous dose of pertuzumab, they were similar to those that were found earlier for the subcutaneous that is rituximab and subcutaneous Herceptin, that is trastuzumab by Roche. The safety signal, so the study did not find any new safety signal for pertuzumab subcutaneous alone, or when it was co-mixed with the pertuzumab or with the fixed drug combination, that is FASCO. This is another study, Frederica study. This is phase 3 non-inferiority study for assessing pharmacokinetics, efficacy, safety of this combination. So you can see here that the patient, they were confirmed to have locally advanced inflammatory breast cancer who had more than 2 centimeters of the disease or node positive disease, that is stage 2 or stage 3 disease. These patients, sorry, they in the arm A and arm B, both of these patients received dose dense AC combination 2 weekly or 3 weekly, and in the second part of the trial, they received paclitaxel or docetaxel. Either IV pertuzumab plus trastuzumab was given to one arm, or the first drug combination, fixed dose combination, FASGO was administered, whether in the along with the paclitaxel or whether along with the docetaxel. So the investigator tried to find out the PK and safety study in combination both with paclitaxel and docetaxel. The primary endpoint was non-inferiority of of the serum concentration, and the key secondary endpoint were the serum concentration, tumor PCR, and disease-free survival (EFS) and overall survival. So these are the pharmacokinetic parameters for this clinical trial. If you see here, the lower limit of 90% of confidence interval for plasma serum concentration, PROF and GMR of the pertuzumab and trastuzumab, they were similar in the patients who had IV preparation or who had subcutaneous preparation. if you see this tumor PCR rates in the intent to treat population, or as per body mass index, the tumor PCR rates were around 59.7% in the FASCO group as compared to 59.5% in the IV group. So the tumor PCR rates were also in line with the IV preparation. So intent to treat population, they were all same, although few number were the less in the obese patient or the underweight patients, but in overweight patients or the normal patients, the tumor PCR rates were even more as compared to the IV population. So tumor PCR rates were close by in both the subgroup intent to treat population. If you see the safety profile of this fixed dose combination, uh, it was almost similar. You can see any event was 99% clear and it was 100% clear. 52.8%, 48.8% for grade 3 adverse event. Death same, and discontinued due to any kind of adverse event. In the IV preparation, they discontinued as compared to the fixed dose combination. So rate of the treatment discontinuation, they were similar in both the arms. You can see here that the alopecia, nausea, diarrhea, anemia, they were almost similar. So none of the side effects, they were more in the fixed dose combination as compared to the IV combination. And similarly, here are the rates for the cardiac dysfunction and neutropenia, febrile neutropenia, anaphylaxis, severe mucositis. You can clearly see here that almost all of them, they were similar. The interest were for those patients who had cardiac event. So you can see here that the p-value for the cardiac events was not significant, and there was no meaningful difference in the cardiac safety between the treatment arm. So this fixed dose combination subcutaneous showed non-inferiority of pharmacokinetics versus IV with comparable efficacy and safety. Tumor PCR rates were similar. Safety profile was similar. No new safety signal they were found. Diarrhea, febrile neutropenia, cardiac safety, hypersensitivity, mucositis, they were almost similar in both the arms. So another question, whether patient prefer to have fixed drug combination or IV combination. So this was the Franska trial, and basic question here was whether the patient would prefer having IV combination or whether the patient will have preference of subcutaneous combination. So these were the patients. They received pertuzumab plus trastuzumab IV 3 cycle, and then in the crossover period, the patient received 3 cycles in the subcutaneous formulation. Similarly here, initially these patients received subcutaneous formulation, and then these patients received 3 cycles IV. So this was 1:1 randomization. These were those patients who had completed their neoadjuvant treatment surgery, and now they are on the maintenance treatment. So half of the population received IV first, followed by subcutaneous, and half of the population received subcutaneous followed by IV. And these are the important things which came out of it. So if you see the preference for subcutaneous formulation is clearly more even with the patient. So preference for the fixed drug combination FASCO was for very strongly and very fairly among the majority of the patients. So 93% patients preferred having this drug subcutaneously, and main reason for subcutaneous preference was less time in clinic. 42% patients said that, and 26% patients said that they were more comfortable with the subcutaneous administration. 87% patients chose FASCO to continue over IV treatment in this clinical trial. So the patients, they were either satisfied or very satisfied with the combination. 85% patients, they were very satisfied. So majority of the healthcare practitioner also felt that switching from IV to subcutaneous formulation would save time and resources. 88% of the practitioner thought that it was the quickest form. The preparation time was very short for this subcutaneous formulation. and 87% of the HCPs felt that the subcutaneous formulation had less number of resource uses for preparation and administration. 77% of the HCPs agreed or strongly agreed that ready-to-use Phasgo combination resulted in the less drug wastage. Administered, it is the 300 minutes which are needed, but for the subcutaneous preparation, it is 33 to 50 minutes, including the observation period. So the main reasons, patient satisfaction, yes. HCP's perception on the time and resources, yes. And the safety profile similar for both of them. The patients and the HCPs, they were very satisfied or satisfied with the drug combination, less time in clinic and more comfortable administration. So what are the practical considerations for using fixed dose Phasgo combination subcutaneous in the real world practice? So this is the tip to ensure that the comfortable drug delivery is to be done. Ask the patient to sit back in the reclining chair or bed to make thigh area accessible. Be sure to arrange that the chair is right at the level of the patient and your feet, they're not twisting or bending, and the feet, they're really flat on the floor, that so that the administration is really easy. Ensure that your hands are in good position and in resting condition. This will reduce any unnecessary movement during injection that might cause discomfort for the patient. The injection site should be alternated between left and right thigh. And once you have used injection site, the next site should be on the left leg or the right leg in the next injection. And in the next to next injection, at least there should be more than 1 inch gap when you are using the previous limb for the treatment. And you have to choose the area of the skin that is not red, that is not bruised or tattooed or tender to touch, and record the use site for the patient's note. To administer the injection, pinch the skin of the thigh in the one hand to create a fold, and this makes it easier to get injection into the subcutaneous space. And do not put the injection into the muscle. That muscle can be damaged. Inject and maintain the needle at the angle of 30 degrees. If there is a point during the injection that patient feels pain or discomfort, ease of the injection before continuing. Keep the needle in place and check to make sure that injection is right at the 30 degree. Injection should be slowed or paused if patient finds that there is significant injection related reaction. The injection should be discontinued immediately if there is a chance or experience of hypersensitivity. Make sure that the injection to treat reaction in the emergency equipment is available if you are using Phasgo in subcutaneous formulation. The patient, they should be observed at least for minimum of 30 minutes for the sign of hypersensitivity symptoms or the administration related reaction if patient they are being administered. After the maintenance dose, the patient should be observed minimum of 15 minutes. So these are quick tips to administer this drug safely. If the drug is administered in the chemotherapy daycare unit, the curtain or shade should be used so that patient should be at privacy. A blanket on the top of the lower abdomen and the pelvis can be used so that the patients feel more safe and secure. So we usually follow these procedures when we do Phasgo for our patients. So this is the overall summary. Phasgo is the first formulation in the oncology to combine two monoclonal antibodies, that is pertuzumab and trastuzumab, in single vial, and it offered faster and less invasive method for the administration as compared to the IV treatment. The PK safety and safety analysis PK and the outcome, they are almost similar. Tumor PCR rates, they were almost identical in the intent to treat population, and it were not impacted by the body mass index. Majority of the patient feel that this is a good combination. Majority of the HCP also feel that this is a good combination, and most of the HCPs, they are now switching from IV infusion to the subcutaneous injection to save the time and resource. This drug is now FDA and EMA approved for the same indication as a type of IV preparation of pertuzumab and trastuzumab. Thank you so much for your patient listening.
Dr. Manish, uh, hello, Dr.
Hello.
Manish.
I think
Hello,
so.
am I audible?
He's lost connection. Yes, sir. Very much. You are audible.
Okay,
I
okay,
think
okay.
Dr. Manish might have lost the
Hello,
connection. Yeah, he's
Dr.
there.
Manish, yes, you are audible. Can you
am I audible?
listen to us? Yes, yes. Are you there? Yes, Dr. Manish.
Gitika?
Yes, sir.
Gitika, hello.
Yes, sir. Your voice is audible.
I'm audible. Okay. So,
Dr. Manish, can I ask a question on FESGO?
Dr. Rajat, hello.
Hello.
Sir, your voice is audible. Listen.
Hello, am I audible?
Yes, you
Yes,
are
sir.
audible.
Yes, sir.
Yes, yes,
Are we audible to you?
yes,
Yes.
Dr. Rajat, yes.
So, do you think that there is any subset of patients, maybe I'm talking about a particular, weight-based dosing, which we always used to do with trastuzumab, that is, not possible with FESGO. So, any
Dr. Rajat, you are not audible. Hello. Gitika, so we move on to that session. I think Dr. Rajat is having problem with the network.
Yes, sir.
So,
Rajat, sir, are you there?
I invite Dr. Vikas Talreja. Dr. Vikas, Gitika, Dr. Vikas is here.
Yes, sir. He is also joined.
Dr. Vikas, good evening.
Once I check, sir.
Dr. Vikas, good evening.
I hope I'm audible and visible.
Yeah, Dr. Vikas, good evening. So,
Very good evening. Very good evening. I hope everything is fine.
yes, yes, yes. So, our session is delayed. So,
Wonderful. I was listening to the sessions and it was a beautifully crafted, handcrafted, I must say. Very important, very relevant issues right now.
thank you so much for being here, Dr. Vikas, Dr. Samit, and I will hand over the session to you. This is a session sponsored by Eli Lilly. Dr. Vikas is a consultant in the Department of Medical Oncology in Regency Hospital, Kanpur, and he will be speaking on, and this session is basically sponsored by Eli Lilly, and this session would be on abemaciclib. There will be case presentation by our two eminent speakers. Dr. Samit Purohit has also joined, I think. Dr. Samit is a consultant medical oncology in Akshay Cancer Institute, Action Cancer Hospital, Delhi. So first case presentation is by Dr. Vikas Talreja, why I should choose abemaciclib for my hormone receptor positive MBC patient with poor prognostic factor. Dr. Vikas, over to you. Dr. Vikas?
Yes, perfect. I hope I'm audible, and
We are not able to hear you, Dr. Vikas.
I hope I'm audible right now.
No.
Dr. Vikas, you are audible. I think there is some issue with the Dr. Manish side. Sir, you need to
Yes,
check your
yes, Dr.
network.
Vikas, you are
I think
audible. Please go ahead.
speakers में कुछ problem हुई है.
Yeah.
So sorry. So please go ahead. Please go ahead.
Perfect. So I will request the team to share the slides on my behalf. And it is important that we discuss this important topic, especially in the updates in the breast oncology, because no updates has been complete without the use of the CDK4/6 inhibitors in a hormone positive subset right now. And we have our personal experiences of many patients, and everybody who has used this knows that this molecule has revolutionized the way we treat breast cancer, especially the metastatic hormone positive breast cancers over the last many years. And
Also, wait for the second, sir.
no issues. So definitely, when we are talking in terms of the metastatic breast cancer, everybody has their own stories. Everybody has their own living tales to tell. It is important that we discuss, especially those where we have a gray area. Mine is one of the beautiful cases where how we see a palliative intent becomes a curative intent, especially with the coming of these extraordinary molecules who gives us so exceptional responses that we haven't imagined when we started our medical oncology career. With the forthcoming of the hormone positive breast cancers, the CDK4/6 inhibitors, and especially abemaciclib has revolutionized how we treat these molecules. So my patient was a very simple case. I would say it was just like a bread and butter with one who presented with an extensive disease and who got an exceptional treatment with the CDK4/6 inhibitors. Maybe it has now become a routine treatment with the way we see the CDK4/6 inhibitors produces a response, and the durability of the response and the tolerability of these regimens. We feel we should have these molecules much before we had in India, and we could have saved a lot of many patients beforehand. So my patient was, you should go to the slide number 5, I believe, right now. Let's put it on full screen so that, yes.
Geetika, do it read only after enable editing. Yeah.
Perfect. Next. So she was a 52-year-old female, presented in August 2020, small lump in the right breast with a fit performance status. On examination, a subclavicular lymph node was there. Ultrasound and mammography showed a Barrett's 5 with an axillary and subclavicular ipsilateral lymph nodes. Looked like a locoregional disease, but when you do a scans, you find out the upstaging of the disease. Next slide, please. And you get she was on biopsy a hormone positive, strong hormonal positive, ER positive, PR 10% positive, and HER2 negative. Next slide, please. So CT was done, which was suggestive of again lymph node and subclavicular metastasis. PET was done, which showed that there were mediastinal lymph nodes uptake and a thoracic vertebral metastasis. Next slide, please. So she was started on September 1st, 2020 with letrozole abemaciclib. There was only one episode of grade 3 neutropenias, no dose reductions done. Next slide, please. On the next follow-up, she had a complete regression of a subclavicular lymph node. There was the breast centimeter, the lesion was completely disappeared from 3 centimeter to 1 centimeter. There was a complete regression of the previously active lesions on the PET scan. And that response was continued in the further subsequent visits also. In March 2021, there was a clinical and metabolical complete response. Next slide. And you could see on those scans, all lytic areas, all light up areas were completely disappeared. And even after 6 months of the therapy, she didn't show any signs of the disease activity anywhere across. Next slide, please. So she took a second opinion from the surgical oncologist because she was having an exceptionally complete response outside the area. And she was offered a radical surgical mastectomy and axillary lymph node dissection. On histological examination, there was a residual tumor of 1.5 centimeters with negative surgical margins. The 5 involved lymph nodes were completely positive among the 13 which were excised. Next slide, please. After the surgery, she took a second opinion with the radiation oncologist. She received a radical radiotherapy and a stereotactic radiation on the 7th vertebra. Next slide, please. And then she came for an adjuvant treatment to me. And again, I prescribed her again with letrozole and abemaciclib. And patient is still doing well even after 21 months of the therapy. Brilliant, complete metabolical and clinical response even after the treatment of it. Next slide, please. So we always have these common situations where we have an oligometastatic luminal breast cancers. We have a tendency to start chemotherapies, but CDK4/6 inhibitors, as we know, have revolutionized the way we treat our breast cancers. And that's why I choose the lesser toxic, more effective regimen. And we could see those results from an oligometastatic. She became a completely curative intent treatment. And I don't intend to stop right away also because of the sustained response she has right now and the curative potential she is in right now. Next slide. So I will ask Dr. Sameer Purohit for his experience also, sir, because it is important that we discuss on a public platform these cases and share our experiences because this molecule definitely is different by design.
Thank you, Dr. Akhil. That was a very nice presentation, especially a metastatic case converting into a curative intent. And I think at the outset, I would like to thank Dr. Manish as well for inviting me on this forum. I'll just share my slides here. So can I be given the rights to share?
Yes, sure, sir.
So I believe my slides are visible now.
Yes, sir, it's visible.
So yeah, so these are my disclaimers. And I'll be presenting two cases here. The first case is a 59-year-old postmenopausal lady who came with the left breast lump, and she had a hard and fixed ipsilateral lymph nodes, and the biopsy suggested IDC. Her receptor status revealed that her estrogen receptor was 70, PR was 50%, and she was HER2/3+ with a Ki67 index of 30%. PET-CT revealed multiple bony and bilateral lung metastasis. And in view of her HER2/3+ status, so this was actually evaluated outside somewhere, and she had received anti-HER2 therapy, pertuzumab, trastuzumab, and paclitaxel, post 3 cycles where she had a good partial response. And subsequent to that, she received 3 more cycles wherein she had a progressive disease where there is an increase in breast lesion and new bone lesions were seen. Thereafter, she was planned for TDM1 for 3 cycles, and a reassessment scan in November 2021 suggested progressive disease in breast and lungs. So this is when she presented to me, and I planned for a rebiopsy, and the site chosen was lung, and where we found that the receptor status again was high, ER of 70%, PR of 30%, and this time HER2 was negative. So this is the baseline scan. These were all the metastatic lesions. And this was after continuation of 6 cycles of anti-HER2, and this was after TDM1 where this breast lesion continued to progress, and these were the lung lesions. So the patient was offered abemaciclib plus letrozole plus zoledronic acid, and this was in November 2021. And in my early clinical experience, this was post 2 months of treatment. Patient was clinically better. There was a reduced breast swelling, and her appetite was better, and she had gained weight. she belongs to a very remote village in Rajasthan, and the last follow-up telephonically was somewhere in April, where she was mentioning that the breast swelling had come down by 70 to 80%, and she was clinically much better. I had requested her for a PET scan, but she has not yet reappeared till now. But I believe she's doing well. So this was my first case. And coming to my second case, this is a 66-year-old postmenopausal lady. She was diagnosed with a breast lump, and the biopsy again revealed an IDC grade 3. She underwent surgery, which revealed PT2 and 2A level status. Extraneural invasion was there, LY was present, and this was somewhere in 2018. She was hormone positive and HER2 negative with a Ki67 of 35%. After surgery, she was offered 12 cycles of paclitaxel and followed by AC, the standard practice. Thereafter, she received 20 cycles of radiation till July 2019. She was offered tamoxifen. However, she developed some sort of intolerance to tamoxifen in the form of deranged liver function. She had some transaminitis. So she was switched to exemestane, and this was till February 2021. A reassessment scan in October from 6 months from then revealed PET-CT revealed a new lung nodule, and a repeat biopsy from that suggested that it was a metastatic lesion, and it was HER2 negative and hormone positive. The lab parameters were normal, and this was the lesion. So at this moment, we know that hormone responsive metastatic breast cancer behaves like a heterogeneous disease. There are multiple disease characteristics despite hormone responsive positive disease. And these parameters, when we have seen, usually quantify for a shortened time to recurrence in early stage, patients who present with a visceral disease or a liver metastasis, patients with a high tumor grade or a negative progesterone receptor status are usually the poor prognostic factors. So the patient was already on hormone treatment, progressed on a hormone treatment in a matter of 6 to 8 months. So the right choice would be a fulvestrant plus CDK4/6 inhibitor. However, this patient was quite reluctant to receive any of the jabs. So the patient was restarted on abemaciclib 150 mg twice plus letrozole with calcium and denosumab. And we have seen from the trial results Monarch 3 that there is a significant benefit with respect to median PFS and overall survival benefit as well. When you combine abemaciclib with NSAI versus placebo plus NSAI, and you see the responses, they appear quite early in the course of disease, and the graphs tend to remain separated. So this is the CDK4/6 inhibitor graph plus aromatase inhibitor. So if you quantify the median PFS, it is twice to that of a single agent. Letrozole or anastrozole with a hazard ratio of 0.54 and a statistical significant value. So if with respect to other parameters, other stratification factors, we can easily make out that irrespective of any stratification factor, all the diamonds are lying on left side of the unity, favoring the abemaciclib arm. And if we see the visceral disease arm, which tends to do very poor with respect to treatment response, the hazard ratio was 0.56, and the diamond is just overlapping the bone only disease. So abemaciclib arm was doing quite well in visceral disease as well. Similarly, in patients who were progesterone receptor negative, again the hazard ratio was 0.41. So this tends to show that patients, irrespective of any of the stratification factors, will actually benefit when you add a CDK4/6 inhibitor over conventional aromatase inhibitor, and especially in this abemaciclib arm, which was doing quite well in the poor prognostic factor group like visceral disease or patients who had a shorter interval of a prior endocrine therapy or progesterone receptor status. So with my early clinical experience in this patient developed grade 1 diarrhea. This was starting initially 1 or 2nd week of the therapy. However, it did not require any dose interruption, and the symptoms settled by the initial 2 months. The PET-CT, which was done in February 2022, suggested a significant metabolic and morphological regression of the pulmonary nodule, and a partial response was seen. So this was the nodule before, and this had quite well disappeared in the subsequent scan. So these were my 2 cases. So I think now we'll be going ahead with the moderation, and Dr. Vikas. Dr. Vikas, are you there? Gitika,
Yes, sir. I'll
you've
check
lost.
once.
Yeah, yeah.
Hello, Dr. Samit.
Yeah, yeah, Dr. Rajat.
Hi, Dr. Rajat. This
Yeah.
with the use of Ramivan, how much is the percentage of diarrhea that you've experienced? Because this is a major concern of a lot of clinicians for the, or maybe I should say, the reservation against the use of Ramivan. So, what is your thought process regarding the diarrhea part? Do you reduce your doses when you're starting, and how much of diarrhea you've reported with the maximum dose that you've used in the patients?
So I would say the trial data suggests around 80% would develop diarrhea. I have seen personally around 3 patients out of 5 would actually develop diarrhea. However, fortunately, in my clinical experience, it hasn't been that bad. I usually add a lot of prokinetics, this thing, Visilax and Enterogerminas along with the Ramivan. And I start with full dose. I don't start with a lesser dose.
Okay, right. And even I have seen that the diarrhea is not to that extent. Probably, maybe Indian patients are less prone to diarrhea, fortunately for all of us. So we don't know, but then probably diarrhea is not as much as what it was in the trial data set.
Definitely,
So
definitely.
I totally agree with Dr. Rajat and Dr. Samit's point, because when we had the experience initially with the trial coming in India, the 200 milligram dose, that was some dose which was definitely diarrheogenic, but with 150 milligram twice daily and our common experience with it, it's very quite common that I usually prescribe and tell them upfront that whenever you have the first incidence of diarrhea, take loperamide, and most of them then don't have much subsequent diarrheas. And diarrhea is something which can be managed locally in their settings also. So that's the best thing when we give abemaciclib, because one thing, the dosing is something which is very, very convenient. You don't have to explain off, on, schedule to a village person coming from a very distant area as when to take, when not to take, whether they have taken a 7-day washout period or not. And the next best thing is, even if they have some side effects and they do CBCs and other things, most of the physicians panic when you give other CDK4/6 inhibitors with the myelosuppressions around. With Remiven, the myelosuppression is not that much, and though no neutropenia, so no need of febrile neutropenias. Diarrhea is also, most of the general physicians are very, very well versed. It can be managed locally. So it is comfortable for the patients also, and for the prescribing oncologist also, to see them once in every month, then rather than seeing them once every 2 weekly with the other regimens.
Yeah, I think that that's a very valid point, and we are very confident that diarrhea is fairly manageable, and it won't be affecting the quality of life of the patient, unlike the neutropenia with other drugs. So that is one aspect, and I haven't seen to the tune of 80% in my patients. So fortunately, like Dr. Rajat said, Indians are much better tolerating this drug. So,
I have
Doctor, yeah.
I have a case where this patient was actually started on ribociclib by me, and she was a metastatic hormone receptor positive HER2 negative disease, and she was a 70-year-old lady. She's still doing very well, 70-year-old, and you do tell them that if you have issues regarding mucositis or any fever, you have to report. This is what was told, and the only issue that she had was, and she was not having any comorbids. The only issue that she used to have is a grade 3 neutropenia, which is very much expected with ribociclib. And over the next 3 to 4 months, she had a very good response also. But from 5th month onwards, she started having very frequent episodes of UTI. And that UTI used to be like for 10-15 days, extremely severe. Again, antibiotics, oral antibiotics at times. IV also was given. And then again, she was fine for one month, and then again the UTI had started to happen. So I referred the lady to my urologist, and my urologist said that probably, according to me, the neutropenia is the reason for UTI, and you should stop your this tablet, and probably the UTI will be fine. So the tablet had to be stopped. Actually, Crixana had to be stopped, and she was continued only on letrozole, and the UTI became better. And then this time around, I did not restart Crixana. I actually shifted the patient to Ramiven, and then there was no neutropenia after that, and trust me, there was no UTI as well. So I mean, a case where how important it is for us to not have myelosuppression is what I'm just talking about.
So Dr. Vikas will go ahead with the moderation, right?
Yes, definitely. Yes.
Yeah. So I think the first question which is here is, does the endocrine resistance status of the patient impact the use of abemaciclib?
Definitely yes, because we definitely have in our common situations a disease even though we believe it's a hormone positive, and we have given endocrine therapy, and we find we have a metastatic situation upfront to deal with because of the endocrine resistance and early endocrine resistance. And especially we have seen this molecule working in a situation where other molecules have failed miserably. The poor prognostic factors, the PR negative subgroup, the high Ki67 subgroup, the liver metastatic subgroup, and also in those who were an early endocrine resistant population. So for me, it is important that we look at the biology of the disease, because the tempo with which the disease progresses, the time of the endocrine resistance is also a very important factor that has been interplayed in various trials the Abema was part of. And that's why that negative um, uh, prognostic subgroups was a characterization for a selection of this highly effective molecule, which has its continuous regimen, which plays a very important role, especially in this negative prognostic subgroup of our patients.
Yeah, so this is, I think, an edge with abemaciclib over other drugs, that primary endocrine resistance, which was included in Monarch 3, is in this particular subset. Abemaciclib does better. And in my personal experience, I had a patient who was started on palbociclib. This was 3 years back. Patient stayed on palbociclib for about a year and a half, and then he progressed with brain metastasis. And somewhere down the line, I reintroduced abemaciclib in this patient, 200 mg OD, and he did better. He did quite well for another 4 to 5 months, and then I lost that patient. So, and there have been studies that have suggested that patients who have been on previous CDK4/6 inhibitor like palbo, abemaciclib does still work. So I think that is one important thing to keep in mind. So how does the selective inhibition of CDK4 versus CDK6 matter? And what does this have on your choice of CDK4/6 inhibitor?
So it is important that when we use a drug, the off-target side effects it has a very important clinical and biological implications for it. And that's why the selectivity of our molecule to the on-target and the less off-target mechanisms make it much more effective. The CDK4/6 inhibitors, probably Ramiven, has an edge over it in terms of the lesser myelosuppression it produces, which is an off-target effect of other CDK4/6 inhibitors. So if on a Monday morning I have a case where there's an extensive skeletal mits, I have a reservation of using an off-target adverse events of other molecules, because we don't know that neutropenia becomes a febrile neutropenia and a life-threatening complications. For me, for that on-target effect of this drug is much more important for it. And that's why it is important for us to choose among the plethora of options we have for the CDK4/6 inhibitors for a molecule to have its on-target effect and lesser off-target effects. And also, I am a great fond of the continuous daily dosing in terms of the off and on dosing in terms of the others, because you have to look for the ECGs in other patient in other CDK inhibitors, the QTC off-target effects of it. Also, you have to look at, especially you have to look at the endocrine partner, whether you are giving which endocrine partner you are giving, because most of them tend to have the prolonged QTC interactions along with the tamoxifen we use. So I am a quite well fond of the CDK4/6 inhibitor MB1 in terms of its more on-target affection, more selective nature, and a continuous regimen it has with it.
Yeah. So in your experience, how important is the delay to chemo, which is achieved by Abima for all these patients?
So for me, again, it is very important because we have seen in past many of our patients that the hormone positive subgroup doesn't have an exact similar response with the chemos as compared to an hormone negative population. And no matter how intensive you give these chemos, those pleural effusions, those hormone sensitive nodes, they don't disappear with the chemos the way it disappears with these therapies. So I believe the CDK4/6 inhibitors, they have a very early onset response and the durability of this response. So with the range of molecules we have right now, and also a good second line PIK3CA inhibitors that we have in our molecules, chemotherapy is something which we never discuss in many of our patients when they are hormone positive metastatic breast cancers, because we know that we have a good range of arenas of therapies to offer. And also the CDK4/6 inhibitors, when you look at the time on an average, the PFS of it, 2 years, you're going to say a patient that you're not going to see chemos. That means a lot, especially in a metastatic situation, especially when the patient does have a response with a single tablets, the quality of life is preserved, their hairs are preserved, their body is preserved, they can lead a normal life, they can plan ahead, and they have good exceptional responses to it, a good disease control rate, and an improved overall survival. That all means a lot to metastatic breast cancer patients, I believe.
Yeah, and besides, it's quite easy to convince a patient to take a tablet rather than chemo, so patient is happy. So, which is the most efficacious of CDK4/6 inhibitors for patients with liver mets? If you compare the data from all these three CDK4/6 inhibitors.
And we have seen in and discussed over multiple discussions that yes, this group of patients is one of the most worst performing out of all the subset analysis when we do for an hormone positive metastatic breast cancer. Once you have a liver mets, that's a negative prognostic factors down and out straight away for upfront. And that's where this molecule works brilliantly, because once you are with liver mets, you would have earlier been tempted to use chemotherapies to get a response and then put them to other molecules. But with Remiven right now working as beautifully and much more better than the chemotherapies in this subgroup, gives us a good ray of confidence that yes, even though the patient has liver mets, he's not in visceral crisis, we will be using our Remiven upfront and reserving chemos down.
So I think this is a question which we have discussed previously. However, just to highlight a few patients' attributes or characteristics that will make you choose abemaciclib right away, whether it's a Monday morning or a Saturday morning.
So for most of my patients, the convenient dosing regimen, the side effect profile. So those patients, especially with extensive skeletal mets, those patients with a CNS disease, leptomeningeal disease, brain metastasis, those patients who are PR negative and endocrine resistant population, those patients with liver metastatic, those patients who have uh, 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 come from a very far away areas also, so making them lesser travel and a convenient dosing regimen, I believe, is something which we all practice a lot.
So just to put it another way, do you have any patients or a group of patients which you would not offer abemaciclib?
That's something which is I would say that with the available data to deny a CDK4/6 inhibitors in a metastatic breast situation, the only thing I would be those who have a visceral crisis. That will be the situation I will be using chemotherapies. Otherwise, all patients with the CDK4/6 inhibitors, my preference of choice is Remiven as compared to others.
Yeah. And what are the toxicities do you would you want to monitor with all these three?
We usually do the complete we look for the neutropenias, anemias, thrombocytopenias. We look for the diarrheas with the Remiven. QTC is interval which we always calculate and look for whether they are prolonging. Many of the offending drugs concomitantly used along with the CDK4 inhibitors are notorious for the QTC prolongation with it. And that's where we need to look and calculate those boxes very carefully. I believe these are some of the most common toxicities which we usually monitor for our routine CDK4/6 molecules we use.
Yeah, so just like Dr. Rajat discussed his case, so I have two cases here. So one of my cases was on palbociclib, developing recurrent neutropenias, and eventually the patient, after 10 or 11 months of palbociclib, developed pneumonia, for which I had to stop palbociclib, and he was not willing for any other treatment. After that, he was just on a hormone tablet. Even the pneumonia was managed with antibiotics, and he's doing well on only single agent hormone treatment now. The other patient was on ribociclib. Patient received 6 months of ribociclib. He had a good response in the interim scan after 3 months. 6 months scan, the patient at baseline, he had lung metastasis. So there was always some element of breathlessness, which continued, which was improving with time. The 6 months scan actually showed better result. However, 2 days later, I lost that patient. She had a fall in washroom, and I don't know, it could be an embolism or some cardiac arrhythmia or something like that. But these are two cases which I feel does tell us about the toxicities of that particular drug. So I just wanted to share on this forum. And what is your opinion on abemaciclib's unique continuous dosing schedule? I think this you have already mentioned previously. So what is the impact of continuous dosing on patient adherence with abema? So I think that has improved in our clinical practice. Final word about this from Dr. Vikas.
I also totally agree, because you don't have to explain the on-off dosing regimen. You don't have to ask them whether how long they haven't taken. It's because sometimes they take 7 days off, sometimes they take 6 days off and start on the 7th day. So it is sometimes very, very tedious for us also to look at those intricacies for these patients. With abema, you know you are safe, and that continuous dosing is something which I am very fond of right now.
Yeah, so that adherence, that compliance is not an issue. The T half of this particular drug is around 18 hours as compared to the other two, which is around 28 or 30 hours. So you require a dose breaking in that, not with abema. So it's a good drug and easy drug, and the data which is coming through does suggest that the oral survival has improved further with it, somewhere closing around 66, 67 months. So I think, and with the single dosing in the metastatic setting and the way it is coming up in adjuvant setting and high risk cases, I think it's a good drug and a drug to stay. And with more hands-on training with this particular drug, I think we'll be more confident in choosing our patients. So thank you, Dr. Vikas, for very apt and very nice answers to all my questions. And with this, I'll thank you all, and back to organizers.
Thank you. Thank you very much.
Thank you.
Thank you, Dr. Samit, Dr. Vikas, for a very engaging discussion on abemaciclib, how to really go about using this a very important molecule and where to fit in our patients this particular important molecule. Thank you very much. So now we move ahead, and the last talk is going to be by Dr. Bharat Vaswani. Dr. Bharat sir is a senior consultant in Yashoda Hospital, Hyderabad, and he's going to talk us through the updates of ASCO 2022 in breast cancer. Dr. Vaswani, over to you. Hello, Geetika.
Hello, supporting, please play the recording.
Good evening, friends. Let me thank Dr. Manish and Dr. Rajat, my close friends, for the kind invitation. The topic that I'll be discussing in the next 20 minutes is what were the new updates in this year, ASCO 2022, with relation to breast cancer. So in a nutshell, I'll be covering the following 6 things. Some are practice changing and some slightly clear some of the questions that we have in our clinical practice. The best and the practice changing study, and probably what got a standing ovation, was a Destiny 4 study, which was presented by one of our Indian, Dr. Shanu Modi, trastuzumab deruxtecan in HER2-neu subset. The final overall survival of Paloma 2 study, highly eagerly awaited study. A phase 3 data on Tropics 2. So antibody drug conjugate secukinumab govitecan in hormone receptor positive. Remember your ASCENT study, which was in hormone receptor negative, and there were answers to few of the important questions that probably we keep on doing in our clinical practice, but for the first time we had our proof of concept. Can CDK4/6 inhibitor can be given beyond progression? Can radiotherapy be avoided in early breast cancer undergoing breast conservation surgery? So early T1 stage who are luminal B, can we avoid RT? And one of the most important thing again was, we know that bisphosphonates are recommended in adjuvant setting along with AI. The question there, this was answered, was can denosumab be given in post-menopausal early breast cancer taking AI instead of zoledronic acid? And now we have a OS data also, which was a positive study. So I'll be covering it into 2 ways, hormone receptor positive and basic HER2-neu related, which is low or non-amplified. Let me start with hormone receptor positive thing. So the first data that came, our first phase 3 where that was an eagerly awaited study, was the final OS data of Paloma 2. Everyone remembers the PFS, which was twice, and the first CDK4/6 inhibitor, which showed advantage in metastatic setting. And this was the final overall outcome of Paloma 2, which is a first-line palbociclib in de novo HER2-neu hormone receptor positive, HER2-neu negative metastatic breast cancer. So palbociclib plus letrozole versus letrozole in postmenopausal women with ER positive, HER2-neu negative, no prior treatment in advanced disease. The primary endpoint, which had been published earlier, was positive with the PFS, and in this we had a final overall survival analysis. Now, without going into detail, the final OS was 53.9 months as against 51.2. Not statistically significant. So unfortunately, the secondary endpoint of this trial, that was negative, palbociclib did not prolong overall survival. Now, they did some subset analysis where there was a subset of patients, you remember, they had taken around 20% of the patient where the disease-free interval was less than 12 months, as against other studies which did not take it. So if you exclude that subset, for a subset of patients where the disease-free interval was more than 12 months and they were taken the OS was 64 months versus 44.6 months, with a statistically significant reduction in the risk of death by 27%. But please remember, that was not a subset planned analysis, and that was an exploratory analysis. So all in all, Paloma 2, a first-line data, was a negative study. Probably multiple reasons could be there, but one of the important reasons was the heterogeneous population taken in the study. Probably some differences between the three, but for now, this was a negative study in terms of OS, but that was a secondary endpoint, not a primary endpoint. Now coming to my second study, can we give CDK4/6 inhibitor beyond progression? So this was a randomized but a phase 2 study of fulvestrant or exemestane with or without ribociclib after progression on any anti-estrogen therapy plus a cyclin CDK4/6 inhibitor in unresectable or metastatic hormone receptor positive HER2 negative cancer. That is a maintained study. So if you see in detail, these were ER/PR positive, progression on endocrine and any CDK4/6. More importantly, either no chemotherapy or at the most one chemotherapy had been taken in a metastatic setting, given ribo plus endocrine. Please remember, it was both switch most of the patients. So a different CDK4/6 inhibitor and a different endocrine therapy. The primary endpoint was a progression-free survival. Now, these were patients where most of the patient had taken preceding line as a CDK4/6. So we continued CDK4/6 beyond progression on a CDK4/6 inhibitor. However, most of the patient, that is 87%, had taken palbociclib. More importantly, they had responded in the first line on a CDK4/6 inhibitor. So approximately 16 months, and the drug that was chosen was either a fulvestrant or a exemestane. Now, when you look into the primary endpoint, there was twice in terms of quantum, absolute 2.5 months absolute improvement in terms of progression-free survival, and in terms 43% reduction in the risk of progression, which was statistically significant. So yes, it satisfied, or the trial was a positive trial with a statistical significant improvement in progression-free survival. More importantly, 2.5, we need to remember that at 1 year, more than 3 times the patient were progression-free on ribociclib as against placebo. So rather than a quantum of 2.5, the more important is long-term benefit. There were 3 times more patients who were progression-free at 1 year. Now, a subset of patients had already on ribo and they continued ribo beyond progression. And if you look into both these subsets, there was an improvement in statistical significant improvement in progression-free survival. After all, in all other subsets also, whether bone, visceral, age, white or non-white, or 2 or more on endocrine therapy. So that was a positive study. So what is the strength? A first randomized trial addressing the question, a well-designed study. But again, we need to remember that this is a small study and not a practice changing. Probably we will need data from the next 4 studies that I have written here: Palmera, PACE, Amber, Post-Monarch. Probably with these studies, we'll be more clearer in our view that whether we should continue CDK4/6 same or different beyond progression. So the second take-home message is continued inhibition of CDK4/6 beyond progression is feasible. However, we need further studies till it becomes a standard of care. The third study, again an important study in those with a hormone receptor positive, regard TROPiCS-2, a randomized phase 3 study of sacituzumab govitecan. Please remember, a drug antibody conjugate against TROP2 antigen. So we had ASCEND study in triple negative, but this was in hormone receptor positive. And this study for a heavily pretreated patient in hormone receptor positive HER2 negative metastatic disease who had already received endocrine, CDK4/6 and prior chemotherapy. Try to look into the subset of patients. At least 1 endocrine and a CDK4/6, 2 to 4 chemotherapy. So heavily pretreated patient, sacituzumab govitecan versus a treatment of physician choice, which could be capecitabine, vinorelbine, gem or a eribulin. The primary endpoint was a progression-free survival with all the other secondary endpoints. These were heavily pretreated patients. So 95% visceral disease, median chemotherapy cycle 3, and metastatic disease for more than 4 years. So I have very heavily treated patients. Again, this was a positive study. In terms of absolute benefit, 1.5 months, but around a 34% reduction in the risk of progression. Again, I like you to look into the 12 months PFS. So 3 times more patients were progression-free at 1 year with sacituzumab govitecan. So again, exciting time, one more drug option here in a hormone receptor positive metastatic breast cancer. Now, when we talk about the response rates, 21% response rate, 34% clinical benefit rate, but more importantly, around 7.4 months duration of response, which all was statistically better as compared to treatment of physician choice. What about side effects? So only 6% treatment discontinuation, 33% dose reduction, and more importantly, only 2%. So a drug which in a heavily pretreated again continues to show a good response with a manageable toxicity. Of course, the toxicity is like irinotecan, so the active principle of SN31, diarrhea, febrile neutropenia, and some neutropenic colitis. All in all, a safe drug in this line of therapy. So a well-designed phase 3 study, a positive study with 34% reduction in the risk of progression, no new safety signal. But again, I like you to be a bit careful that the quantum of benefit was only 1.5 months. We need to look into OS now, which is still not mature. And although there was some benefit in quality of life, but we need a longer data till we incorporate this drug into the clinical practice. So the third take-home message is sacituzumab govitecan, one of the new options in the management of hormone receptor positive subset. The most important study for today, the practice-changing study and the study which got a standing ovation, trastuzumab deruxtecan in HER2 low breast cancer, the data of Destiny Breast 4 study, which compared this with treatment of physician choice. Now, when you look into this HER2 no, it is defined as IHC 1+, IHC 2+, or in situ hybridization negative. And if you remember, or if you consider overall, around 45 to 55% of the patients are in this subset of patients who are HER2 no. So you can remember how many new patients or how many new number of patients of breast cancer will be benefited from the study. So again, look into the population. These were HER2 low, unresectable, 1 to 2 lines of chemotherapy in the metastatic setting, or recurrence less than 6 months after adjuvant. So a poor subset patient, 1 or more than 1 endocrine therapy, ER, hormone receptor positive disease. So again, a pretreated patient with trastuzumab deruxtecan 5.4 mg per kg 3 weekly versus chemotherapy of physician choice. The primary endpoint was PFS, and the secondary endpoint included overall survival and safety. Now look into the number of treatment. At least 3 chemotherapy systemic lines of treatment had already been taken with the range of 1 to 9. Around 67% of the patient, it was 4th or more line of treatment. Around 61% of patients had taken at least 1 chemotherapy. It was a second line in terms of chemotherapy. And when you look into endocrine, majority had taken 3 or more than 3 lines of endocrine therapy. Around 70% had already received a CDK4/6. So all in all, a heavily treated population. Now, this was unprecedented. A 4th or a 5th line treatment with a PFS of 10.1 months versus 5.4 with the absolute gain of 4.7. A statistically significant improvement with a 49% reduction in the risk of progression in the hormone receptor positive. All in all population also, this hazard ratio was even more impressive with 50% reduction in the risk of progression. So a highly impressive data. Practice-changing data. Now, icing on the cake was an improvement in overall survival also. So close to 3 years, I beg your pardon, 2 years, 23.9 months, a 36% reduction in the risk of death, and an absolute gain of 6.4 in the hormone receptor positive. And these results continue to be same or better in all the patients. Now, when you look into the hormone receptor negative, which was in a minority, this quantum of benefit. So absolute gain of 5.6 months with around 54% reduction in progression. More importantly, again, the OS there was a 52% reduction in the risk in the hormone receptor negative. So both ER positive and ER negative, the benefit was continued, probably more better in the hormone receptor negative subset. A highly impressive response rates of 52.6, or I can say more than 50%, 70% clinical benefit rate, and a very high duration of response of more than 10 months. So what about toxicity? So 53% grade 3 toxicity with, again, less than 1/5 disease dose discontinuation and around 23% dose reduction and a very few deaths. ILDs, what we were about, was less than 10%, and nausea and fatigue was also manageable. When you talk about adverse events of special interest, C grade 3, 4, 5, TDXD less than 2%. When you talk about cardiac, grade 450. When you talk about cardiac failure, grade 450. So all in all, the drug which was the side effect was as we discussed previously, and it was manageable. So if I have to summarize this, a practice changing studies, around 50% improvement in the risk, in reduction in the risk of progression, and more importantly, 36% reduction in the risk of death when we give this drug. The first anti-HER2 antibody to demonstrate this in HER2 low, similar benefit across all, safety was manageable. So the 4 take-home messages: TDXD now a new standard of care in HER2 low subset of patients in this one. We remember these are 50 to 60% of all breast cancer patients. What about early breast cancer? So in next 3 minutes, I'll finish off these things. An important question, Lumina study. Can we avoid radiotherapy following breast conservation surgery in early luminal A? So less than 2 centimeter T1 luminal A breast cancer, and probably one of the good studies that was published. So basically they try to determine in these low risk subsets, so combining clinical pathological factors and luminal A to see that whether you can avoid radiotherapy in this subset. So please try to look into it. T1 more than 55 ER positive with a Ki67 of less than 13.25%. And the main thing was that the local recurrence rate should be less than 5% at the end of 5 years. So what they observed was in this subset of patients, when you omitted your radiotherapy, the local recurrence rate was only 2.3%, less than 5% that they had thought of. Now, when you look into the other recurrence rate, 1.9% contralateral breast cancer, any recurrence 2.7%, a DFS of 90%, but more importantly, overall survival of 97.2. So they thought of 5% as a local recurrence, it was only 2.3. So probably what they concluded is, yes, this approach is feasible because anyhow, the local recurrence rate is only 2.3%, and it satisfied the pre-specified boundary. And it supports that this, we can think of omitting the RT in this low risk subset. So the 5th take home message is, considering the low risk of relapse in this subgroup of patients, we can think of omitting radiotherapy. The last study, we have remembered that we normally nowadays, or we gave zoledronic acid every 6 monthly in post-menopausal carcinoma breast patients who are on aromatase inhibitor. What about denosumab 60 mg every 6 monthly? We already had a fracture reduction data in 2015, but this was the final survival analysis in this 3,425 Austrian breast cancer study group 18 study. One of the most, again, talked about studies. So early breast cancer, ER/PR positive, randomized to denosumab 60 mg subcutaneously 6 monthly versus placebo. So you should not have taken bisphosphonate. Now, this was something that was published in ASCO 2015. There was a statistically significant improvement in terms of time to first clinical fracture, 50% reduction in the risk of first fracture. But this was what that was published in this ASCO, a statistical significant improvement in disease-free survival. 17% reduction, but more importantly, 5.4% absolute gain in disease-free survival at the end of 5. When you look into bone metastasis-free survival, again, a statistical significant improvement of 19% with an absolute gain of around 5%. And more importantly, again, even in overall survival, the gain was there of around 5% with a 20% reduction in the risk of progression. So that is something amazing. Apart from reducing your fracture risk, it also improved DFS as well as OS. So what did this study conclude? That Denosumab 60 mg every 6 monthly during AI therapy is safe and markedly reduced treatment-induced clinical fracture, but more importantly, disease-free survival, bone metastasis-free survival, and our overall survival was improved by giving this drug. So now we have one more drug apart from bisphosphonate that we can give it in every 6 monthly. There is some advantage in terms of avoidance of hypersensitivity. You can give it in a renal failure patients also. So the sixth take-home message was denosumab along with bisphosphonate now the standard of care in adjuvant setting in patient on AI. You can give your bisphosphonate or you can give denosumab, for then we have a OS advantage also. The last thing, should I give a GnRH analog in those patients who are premenopausal and after chemotherapy still menstrual function is retained or the patient is premenopausal? So this was the trial which combined tamoxifen with gosiranen. Please remember, gosiranen is given only for 2 years and the primary endpoint was a disease-free survival. So the primary endpoint at 8 years was statistically significant. I practice this. If the patient is still menstruating, I give 2 to 3 years of GnRH analog. And this trial also suggested that there was an absolute gain of more than 5% with a 33% reduction in the risk of disease progression at 8 years. So yes, we have a data now to support it. OS, since it was across, the OS was not statistically significant. So the seventh and the last take-home message is adding ovarian suppression, an important consideration in women retaining ovarian function post-chemo in hormone receptor positive early breast cancer. So even after chemo, if you have the menstrual, you can add on to improve your DFS advantage. So if I have to summarize my breast cancer update in this, if you can remember this, you might have covered everything. Paloma's 2 study failed in a secondary endpoint. Continuous inhibition of CDK4/6 beyond progression is feasible. Sacituzumab govitecan, again a new treatment option in hormone receptor positive metastatic breast cancer. Trastuzumab deruxtecan, new standard of care in HER2 low metastatic carcinoma breast. Radiotherapy can be omitted in subset of early breast cancer patient undergoing breast conservation surgery. Denosumab, a treatment option in adjuvant setting in postmenopausal patient with a survival advantage. And last but not the least, adding GnRH analog along with hormonal therapy in patient retaining ovarian function post-chemo improve your disease-free survival. I thank you all, and I always say this is one of my previous quotes. The secret of change is to focus all of your energy not on fighting the old, but on building the new. And I again thank the organizers for the kind invitation. Thank you all.
Thank you. Thank
Good
you, sir,
evening.
for
Good
a very
evening.
nice
First, sincere apologies. I was in
presentation.
some party, so I could not attend there. So I called it early morning. I just came out. Hope I answered or I completely covered. This was the 6th most important abstract. And I think there was a lot of good things that came up in this ESCO 2022.
Yes, sir. Yes, I agree. Sir, what is your take on the use of denosumab? Are you now going to use denosumab in almost all your patients in the adjuvant setting?
Yeah. A advantage in terms of you don't have to give a IV, it is subcutaneous. We all know the other advantages like no hypersensitivity, renal things. So I think so, more or less, actually, we have been using it in those who are not fit for zoledronic acid till now. If you ask me, we have quite a few patients, but now you can safely use in other patients also, because now we have a phase 3 data, which more or less says the same thing, that either you use a zoledronic acid or a denosumab. Being a 6 monthly, I don't think cost will always be a constraint. And I think so that is, again, if you say it is practice changing, or now I can say a practice reinforcing study, because some of us are using it in those who are not fit for zoledronic. Maybe now we can use it for all our patients with the data available, sir.
Okay. And of course, like you said, the most practice changing study is the Destiny Breast 04 on HER2 low patients. So do you think that once trastuzumab deruxtecan is available, it is going to be the most sought after drug for all our patients in the different settings?
Perfect. If you say, if you just remove your triple negative, Apart from that, for all the patients, you will be using this drug. Of course, the quantum of benefit, if you are HER2 amplified, it will be pretty high. If you have seen in the Destiny study, which previous Destiny, which compared it with idotrastuzumab. But the good thing about it, if you are not HER2, if you are not triple negative, you can use this drug in all of your patients. So yes, fully agreed that this will be the most sought after drug and probably a game-changing drug for this entire 70 to 80% of the patient. Now, and again, we need to remember that 10 months was the after it was a fourth line. So maybe if you use it earlier in this HER2 in the first or second line maybe after a CDK4/6, this 10 months might still be 16 to 20 months. Maybe I am assuming, but yes, probably earlier lines, as we have seen in HER2 amplified, the quantum of benefit is more. This was a fourth line average. And with a 10 months fourth line, something that was never thought of also. So probably yes, again a game changer and more sort of drug. Agree with what you said.
Right, sir, right. And of course, now we have a little more validation about the use of CDK4/6 inhibitors post CDK4/6, which some of us were doing because the patients used to have a good performance status and they never used to like the fact that they were going to be started on chemotherapy. So that also is a little more validation now.
Again, if you look into, I'll tell you, if you have a time, go through the flat iron data of use of CDK4/6 inhibitor in US population. In fact, they suggested that post CDK4/6 progression, the best PFS in those who are not PIK3 mutant was continuation of a CDK4/6 inhibitor. So probably in real life, many of us have been using it with the scarcity of the option available. And for the first time, we have a proof of concept. In fact, I'll be more excited when we get the data. For me, Abema is one of those drugs which works very well in a refractory setting. And there are 2 studies going on for abemaciclib. And we know that second agent Abema, as far as Monarch 1 also had a fantastic response. So I think more or less, again, we were using it without any proof of concept. Now, for the first time, we have a data which says that although the placebo arm was only 2.75, but yes, 5 months, but I would again like you to concentrate on a 12-month PFS. So if you respond and if you keep on responding, 20% of the patient was still progression free for at least 1 year more. So that is something that is, you have a long-term response. If you are responding, it is good that you may respond for more than 1 year. So that was more a take-home message rather than this 5.5 months. And I agree, we have been using it, and probably this gives us more proof that what we were doing or what we can do is correct.
Right, sir. And the final question, I'll not hold you for long. I know that you're busy. Is that the last thing about the use of your preference about the first line use of CDK4/6? So Paloma 2, the secondary endpoint was negative. But then do you think that it was just the subset of population that they had taken because there was more pre-treated population than the Mona Lisa 3 study?
No, if you ask me, somehow I feel it could be one of the reasons of that patient with a less than disease-free interval 12 months. But I will like you to leave about your first line. In the second line, the data of Paloma 3 was negative. In the adjuvant setting, Pala study and Penelope study, that was also negative. So I feel there is something more than the drug. I strongly feel that all the 3 drugs are different. Yes, in a first line, I think so. Now with the data available, maybe there is a slight inclination of using a ribociclib rather than a palbociclib, and I'll say maybe a abemaciclib, because unfortunately, if you look into the Abema, people will beat me. If you look into the interim OS analysis of Monarch 3, I'm repeating myself. Monarch 3 is the first line data in an interim is not statistically significant. It is 67 months Monarch 3. That is first line Abema, 67 biggest, but that was not statistically significant. So if you say data wise, Palbo failed in the first line. Abema till now has not shown OS advantage as far as interim analysis. So with the data available, Ribo should be used in the first line with the data. Although I strongly feel Abema may be positive and in a longer run. For a second line, I feel the best data is for abemaciclib, more in the endocrine resistant, but yes, some out in the endocrine after 2 years thing also. So I feel now is the high time that you should think that these three drugs are not the same. And you have what we say horses for courses. You should be individualistic in seeing the situation and then making a choice about things, apart from what you see based on your side effect profile also.
Right, sir. So thank you so much for a very detailed discussion on the new updates which have come, and I believe that most of these updates are going to be not only practice changing, but they are going to be very much into our practice in the coming year or so. So I thank you once again for sparing time for a very nice and
And
detailed
my pleasure.
discussion
I
as always.
absolutely, it is privileged to be part of your we always learn some new things from you. Thanks for the kind invitation.
Thank you, sir. Thank you so much. The feeling is likewise. So now we come to the end of this day one of these oncology updates, and we discussed at length the new updates in the breast cancer. We talked about the PARP inhibitors. We talked about the CDK4/6 inhibitors, and the new combination of pertuzumab and trastuzumab, and of course, not to forget the a very important comprehensive genomic profiling, which was discussed by Roche people in the beginning. So I again thank everybody who was a part of this meeting, and I will urge you all to join us tomorrow at 6:30 for day 2, where we are going to talk about everything possible in lung cancer and what are the new updates in 2022. I thank you all for your active participation, and have a great evening ahead. Thank you.
So thank you so very much, Dr. Rajat sir, and everyone who has participated, including Dr. Manish. So we will see you tomorrow at the same time. Thank you. Good night. Stay safe.
Thank you.